Oh, which is the Some on the walls.
Oh, fine, okay. Just wondering who I should be looking at. Or
Big Brother.
Bwrdd da pawb. Welcome everybody. Welcome to today's Health Board public meeting. I hope you're all well. We've got a fairly healthy, rich agenda to get through during the course of the day. We've made some changes earlier this week to the rhythm and programme of the items we're covering, just to make sure that there's a congruence between the things that we want to cover off. So hopefully the conversation and the discussion will flow during the course of the day. Before we begin, can I just confirm that everyone received the papers in good time? And that they were clear and comprehensive? I should say a word about that a little bit later. Is there anything that people feel has been omitted from the papers, or anything that we would want to discuss that's not included in the agenda? No? Good, okay. And then just to remind everybody of the kind of decision-making principles we try and exercise as we go through the agenda. So those decisions need to be fair, they need to be affordable and sustainable, consistent with our strategy and our strategic approach, not create an unhelpful precedent. So when we make a decision, make sure that it's not committing us to other decisions that we might need to make in the future, and that ultimately those decisions result in safety around patient care and patient quality. Great, okay. We've had a number of apologies today. Anna Lewis has apologised for her attendance. Jonathan Arthur, who's the chair of the Health Professional Forum, and Moape Burke. And Moape, as you may know, has joined the board in a shadow board member capacity. James, I think you will feed back at some point on behalf of Jonathan.
Yes, chair is needed.
Great, okay, thank you. And then we have a number of individuals joining today as a consequence of some of our items. Largely, we will leave the introduction of those individuals until we get to that point of the agenda, which will be at the Ceredigion Community Mental Health Referral Pathway, and also the urgent and emergency care conversation, which will take place immediately after lunch. Can I begin by asking if there are any declarations of interest? No? Could we record for the minutes that there's no declarations of interest? Can I move us to the minutes of the public meeting held on the 25th of September? Is everybody happy to agree the minutes? Yeah, thank you, Claire. They're an extensive, comprehensive set of minutes. Thank you for that. Can we move to matters arising and table of actions? Is everybody assured by the matters that have arisen during the course of the last meeting and the actions that the board has undertaken? Yep. Great, okay. Thank you. If people are comfortable with that, let's move to the minutes of the corporate trustee meeting held on the 25th of September. Are people happy to approve the minutes? Okay. Can we approve those minutes? And also the minutes of the annual general meeting, also held on the 25th of September. Okay, let's agree the minutes of the annual general meeting as well. Okay, and then let's turn to our next item, which is report of the chair. I'm not going to go through this verbatim. 2 points I would like to mention. One is that obviously there's a reference to urgent and emergency care, which we'll take in our conversation this afternoon. after lunch, and the other is Anna's departure as an IM. This would have been her last meeting had she attended today. She served for 8 years as an independent member. She'll represent a significant loss, in my view. The breadth and depth of her knowledge and expertise and her commitment to the work of the board has been invaluable. So we will have an opportunity to say goodbye to Anna before we reach that point, and indeed she will be participating in the public accountability meeting which takes place the week after next. But let at this point just register and record our thanks, Claire, for her service to this health board. Thank you. Can we then move on to the Chief Executive's report? Unless there's any questions or any comments people want to make, or any contestations or challenges? No? Okay. Let's move to the Chief Executive's report.
Diolch Cadeirydd a Bwrdd a pawb. Good morning, everyone. So there's quite a bit in the Chief Exec report, I think, this time. But firstly, the first item you'll see is some changes to the executive team and senior portfolios, and the sort of alignment around primary care and community long-term conditions. So, and you'll note that this is also Jill Patson's last board meeting, which is a big moment because Jill, you've made a contribution over many, many years. So a big thank you to you. Won some great awards, the Lifetime Achievement Award by the RCN in 2023, I think recognised all of those achievements. So Jill, thank you very much for everything that you've done over those years. And I know I've been here for many of them, but perhaps not quite all of them. So I would just move on to the rest of the report. So we've got the operational structure update. So there's a couple of items where I know Andrew would be happy to give an update on, although you'll see in there the update on the operational structure and us moving to phase 2. Also the Prince Philip minor injury unit work, which is now moving, of course, into implementation phase, following our last board meeting where we agreed a way forward, and you'll see the details there. Also, there's a number of petitions that we've received, and we do need to take due regard of those petitions from the public, and they are on key issues that this board is engaged in thinking on and working on. So they're important issues. There's an item on the national maternity assessment, which I know Sharon would be happy to take questions on, but you can see already that there's been a number of engagement sessions, and that we're due to have visits from the oversight panel team. And you can also see that the work on the emergency medical retrieval and transfer services progressing through the JCC, but there's an update later on that. Public accountability meetings have been happening with other health boards. Our meeting is on the 11th of December, if the public would like to tune in to that. That's with, of course, the Cabinet Secretary and the executive team in government. You'll see we're making progress on orthopaedics regionally with our colleagues in Swansea Bay. I think that's really important progress. You can see we're developing we're doing the detailed planning and developing a business case around how we jointly oversee our waiting lists. I think that'll help improve our offer to the public around orthopaedics. A plug to the staff for the staff survey to our staff. We're really trying to push this year. I know Lisa and the team have tried all sorts of different ways to get that filled in and I suppose improve on our rates from last year, which were an improvement from the year before, but we're really pushing that. And lastly, Meddygfa Pren Ryn, you'll see an update there in the board paper, the fact that Shalom has given us notice for the end of December, and we've been working with the community on seeking other options, because whilst that's challenging, we're still working on that. So, Chair, I know that there's a couple of some recommendations there, but I think we would certainly want to hear, I think, from Jill about Myddug for Penryn, but I'm sure other execs or I would be happy to take questions on the other elements.
Great, thank you. Let me just first of all say, on behalf of the board, I was going to say congratulations, Jill, on departing. I don't mean that at all. I mean, we will miss you. You bring professionalism, and you bring discipline, and you bring clarity to lots of things that you've been doing, and we welcome that as a board. I personally have welcomed that and found that to be invaluable. So you will be missed, but with the very best wishes for the future.
Thank you very much.
Great. Perhaps you'd like to share with us any update on St David's.
Thank you. And I think we continue to thank Shalom for the opportunity that we have had over the last year. You remember it was a very difficult search for facilities in 2024, and we did open on the 1st of November in Shalom as a branch surgery with the changes that occurred in Myddug for Penryn. And over the last year, 1,189 patients have used the service in Shalom. Some of those have used that more than once, and 8 patients have used it 10 times or more. So it has been something that the community have really recommended and welcomed. Now, we are back in that difficult situation where the same facilities that we explored previously, we've reviewed again. We've looked at over 10 facilities with our estates team and infection control services and really haven't found a suitable alternative. So we have been doing more work with the Peninsula group to think about what other options that we could have. And when we've looked at the data, we've identified that 60% of the activity that's taken place in Shalom has been for phlebotomy. So what we're pursuing at the moment is an option, and we have got something that we are looking at, whereby as an alternative, which we feel would be reasonable, we would be able to offer a weekly phlebotomy clinic in a facility that we've identified that would be able to provide that level of service, but not necessarily the wider nurse-led services that we have been seeing there. So I'm pleased to report that. It's still a matter for progress and discussion. Our estates team will be visiting that premise very shortly, but bearing in mind that has been the most use for the Shalom service, we feel that if we can offer that, then it would be something that the community will still welcome, whilst then having to go to the main branch for other services. So I'm sure by the next board that service should be up and running actually, and I think we'll be able to report in between in terms of that development. So I'm thanking to all of the people that are helping us to identify those alternatives. Thank you.
Thank you very much, Jill. You've explained the history of it, which I think is really important, because we made a commitment that we would facilitate a branch surgery in St David's, largely to reassure people that we weren't taking those services out of the city, and I think we should hold to that.
Yeah.
I think we have a responsibility to the community to hold to that, and I think if more than 1,000 people have benefited from using that service, I think that's something that actually we should be proud of,
yes,
having ensured that those individuals have not had to travel to receive the service. There's always challenges for us when we think about our cost investment, because we're under such pressure across the broader landscape, the health landscape. But this is one of those examples where it's really important for us to be able to demonstrate we said we would do it, and we will do it, and we will maintain a commitment as we originally indicated to the community of St David's.
Thank you. And I think the changes that we've made to the Myddug for Penryn building as well will allow us to accommodate the wider services that we have been providing in Shalom, should it not be possible to continue with those. But we hope that we will get that phlebotomy service there very soon.
Great.
Thank you.
Thank you, Joe. Great. Okay. There was one or two other questions I had related to your report. The first was in relation to the clinical care groups. We are now in a position where largely these have been in operation for 9 months, 10 months, Andrew? I'm looking at you. Great. So I'm just wondering whether there's a point at which we might want to review their effectiveness in terms of how they're operating and what value they're adding to the way in which we're planning and delivering those services?
Yeah, I think that's I think that's a fair question to ask and for us to look at. I think what I would say is we implemented the new structure on the 1st of April with the new governance arrangements. We're in the process at the moment of an internal audit of how those governance arrangements are working, because a big part of our one of the things we needed to do as part of implementing the structure was address some of the recommendations from Welsh Audit Office over a number of structured assessments around our operational governance arrangements. So I think there's a key element of that will inform where we're at. I think I would say that whilst the CCG structures have been in place, not all of their substructures beneath them have been fully populated yet or completed. So, and with the processes we've been through, which have been really rigorous in terms of recruitment, we've still got a few roles that people haven't yet joined the organisation to take up key roles. I'm thinking particularly in our integrated systems, which are obviously key for us in terms of the urgent emergency care conversation, for example, that we'll have. So they've not been fully operational, I would say, in that sense, in that they've had gaps, and we're still finalising that. I think there are signs that there is a difference and a positive benefit from them. I think we are seeing at local level a far tighter grip, particularly in terms of some of the financial challenge and arrangements. That's been supported by the arrangements we've had in place, like the financial control subgroup. But I think what we're now seeing coming through to that forum is far less than we were seeing 18 months ago. That would not be approvable, if you were saying, because the care groups are filtering that out. And so I think in that space there's definitely some progress been made. I think there's an opportunity through the governance work though around how we can really enable them. Yeah. I think how we can really enable them to fly, yes, and work as we intended them to work when we put them in.
Great. Well, that's partly the rationale behind my question, which isn't just about hunting for deficits in terms of how they're operating, but what more can we do as an organisation to give them sufficient energy and thrust to be able to make a difference. I would suggest, bearing in mind it was March, that we work to an annual cycle in terms of that review process. So I'd like to think that actually by the time we get back to March, we celebrate that 12-month period with a review update of how well we think they've been delivering and anything more we can do inside that space.
Yeah, I would be happy to do that, Chair.
Brilliant. Great. Okay. So in terms of the recommendation from the Chief Executive's report, can I ask that we endorse the Register of Ceilings since the previous report on the 25th of September?
So, a couple of
Maynard.
questions.
Sorry, Maynard. I was a bit premature. Go ahead.
Yeah. Firstly, about the maternity assessments, you did mention these, Phil. The dates for the some of the assessment visits have passed. I'm wondering if there's any feedback from those initial assessment visits last week.
No formal feedback directly from the team. I've spoken with the head of midwifery and they've had the conversations with the staff. Nothing in terms of immediate issues that we need to be considering. This review is through the lens of appreciative inquiry. So the emphasis is on identifying practice that is good and practice that can be shared across the whole of Wales. So at the moment, there's another visit planned with staff in Glangwili next week, and then there's a meeting planned with the senior team and with executive members the week after next. So as soon as we get some feedback, I will share it with the exec team and with the board. Yeah.
That's great. Yeah. So we'll have some feedback from them about good practice elsewhere.
Absolutely.
As well.
Absolutely.
That's really good.
Yeah.
Secondly, was about the petitions at Senedd. The big one has obviously been kept open, but the other two, it says we've had a letter asking for comments about the current status of Glangwili. I'm just wondering if we've issued any comments yet. And on the one below that, on looking at a business case to keep Cardigan minor injuries open 7 days, whether where we are on the business case for that, whether it's work on that has started yet.
So we're going to hear about our unscheduled care system today at board, and so it relates, I think, directly to that petition, and I think all the work we're doing around urgent emergency care that we'll hear about today through the board is directly related to that. So we would agree with the public in the sense that that is an area we need to focus on and we want to improve. In terms of the Cardigan Minor Injuries Unit, I know, and Andrew may be able to give an update, but I know it's something that we're considering over the winter months. Of course, we had the funding last year for it. It's, of course, we know it was well supported by the public and well thought of. It is us trying to work out how we would resource it over the kind of winter months. But in terms of the response back, Joe might be able to give an answer to that, and then Andrew perhaps on where we've got to.
I'm happy to wait for the discussion on UEC on if it's more relevant, so we take it in the round.
It is, I think, because I think your question has a system solution.
Yeah.
It isn't just about the single service, it's about the wider stuff as well, but it's a good question.
Yeah.
So just on Glangwili, we are collating a response to that, so they have asked us for a response, so we're just pulling that together, which should hopefully go in the next couple of weeks. And on the stroke one, I know there's a response to that one being prepared as well, so we haven't issued a full response yet, but they are in progress.
Okay, thanks.
And minor injuries.
Andrew, do you want to, on the minor injuries question?
For Cardigan, sorry. Yeah, sorry, I thought we were going to pick that up. Sorry. In terms, so it's obviously, we ran it over the course of last winter for a period of 7 days a week to test it. It did have a positive impact. As you said, Chair, there's a system element here in terms of how we resource it and make it work. We have had a conversation with Welsh Government, who have expressed previously an interest in trying to help us provide the resourcing to make that a 7-day-a-week service, but we haven't yet had a formal response to the answer to the question they asked of us yet. But I think as we look to, in particular, how we increase 7-day service delivery across urgent emergency care, how services like that run consistently on a weekend as they do in a week on a weekday becomes a really important question for us.
Thank you. We definitely need a wider conversation about it and the value of it, not just in terms of delivering services, but the value to the public. Very helpful. On the maternity stuff, I'm mindful we've had some very good audits of our maternity service in Glangwili not so long ago, because it was reported to this board. That doesn't mean we can be complacent around those services in terms of the Wales-wide maternity review. But I'm hoping that with a degree of confidence, that stands us in good stead to understand that we understand what is a really good service in relation to providing care to women who are having babies, and I think that represents quite a lot in this space. Great. Okay. Can I go back then to just to recommendations? So we endorse the Register of Ceilings since the previous report on the 25th of September. Note the status of the consultation documents received and responded to in Appendix 2. And we also note the executive team discussions. Great. Is everybody comfortable with that? Okay. I think that moves us on to, I'm just looking, annual plan. Yes, please, Lee.
Diolch, Cadeirydd. Thank you, Chair. Good morning, everybody. So, the annual plan paper, I think, is pretty self-explanatory today, so I won't go into a great deal of detail, but it does go to provide a high-level overview of, firstly, the progress with delivering our plan this year, and then secondly, the work that's been done to date to develop the plan for next year. In relation to this year's plan, we will, of course, have the finance and performance papers later, so I suggest we can pick up the key discussion points there. but the highlights are that we're making continued progress with the financial position, and we've now gone beyond what was included in the original plan and moving towards the expectations set by Welsh Government. We have made some progress in urgent emergency care performance, but we'll obviously hear more on that later, particularly in relation to ambulance handovers, but still the system overall is incredibly pressured, and we'll get into some of that discussion in the later item. Cancer performance has stabilised above 60%, but is below what we'd originally set out in the annual plan, and we are seeing limited progress in the areas of ophthalmology and delayed transfers of care. In the summary there, what we've done is presented by exception, so we obviously are delivering on everything else that is not listed there in effect. With regard to the development of the plan for next year, we have recently had a board seminar on the topic, and we discussed many of the key themes coming out of the planning workshops that we've been holding with the relevant teams, and in particular our assessment of the organisational risks. And board members will recall that we are attempting to manage and work out how to respond to over 580 risks that we've categorised as urgent or extreme. So some significant challenges across the organisation for us to deal with. Following board seminar, there has been a further workshop, and the prioritised areas have now been collated for further discussion with board over the course of December and subsequent months. We are, of course, expecting another very challenging financial position heading to next year, and that will mean that has meant we've given a clear instruction to the organisation that the top risks will need to be responded to through resource reallocation as opposed to additional funding, alongside, of course, making significant savings. The process to date has, in effect, I would say, underlined the unsustainability of our current position, with all the risks that I mentioned, and they, in effect, represent an unseen deficit, if you like, in what we would aspire to deliver against what we were able to deliver, and that far exceeds the financial deficit that obviously we'll come to a bit later. So that will require us, through the course of the coming months and beyond, to consider difficult decisions about how, where, and what services are delivered and provided. So we'll obviously come back to that in further board meetings, but just to signal that is the key issue that we're grappling with through this process. So I'm happy to take any questions. Thank you, Chair.
Thank you, Lee. For me, there's a confluence around all of this work, which partly leads to the financial roadmap paper in terms of what do we do in the future? How do we become sustainable in the future? So I think you're right. I think that everything is kind of leading towards that point of discussion. Thank you very much. Maynard, you wanted to come in?
Yeah, a couple of questions. First of all, can I thank you for the paper? I thought it was really clear and well set out. Couple of questions about this year's performance first. First one, delayed pathways of care. Conscious that that's a system based support. Just wondering how much of sorting that problem out is we're totally within our gift and what we're doing about that, and how much we need to work with our partners more and in a better, different way to take that forward. So that was the first question. I'll finish the questions. Chance. Second one on ophthalmology. We're doing a lot of work with Swansea Bay on the regional basis on ophthalmology. I'm just wondering what the impact of that is being, whether it's actually helping the situation or it's just stabilising the situation. And finally, in going forward, looking at the principles in the appendix, we've agreed to take the top 3 risks from each CCG. The CCGs are very different in their makeup, and some of those risks, whilst they're all high or critical, might, when you compare them against each other, need to go deeper in some CCGs than others. I'm just wondering whether just taking the top 3 is a sustainable way of planning, or whether we need to look at other risks as well as just the top 3.
Before you come back, Lee, well, Andrew, you might want to come in on the delayed discharge question, but actually, let's take another question or another observation first, and then we'll take it from there. Yes, please, Eleanor.
Diolch, Cadeirydd. Thank you. And it links to Maynard's question on the delayed pathways of care. The paper is very clear it's systemic issues. I would absolutely like to seek assurance that we are working with other partners. There are different things that happened in different parts of Hywel Dda in each of the 3 counties. And I'm also interested in, are the improvements in UEC and how we're treating that impacting on the delayed discharge? It's about how does one bit of the system impact the other bit of the system? And the local authorities have a key part to play in this area as well as primary care and GP clusters. So I'm seeking assurance that it's joined up in this space. The second question I had was on the cancer numbers. The paper tells me that it's stabilised at 60%. Were the 70 to 80% targets realistic in the first place? And 2, the paper's telling me the process, what's happening, and I'm assured by the process, but it's not quite telling me how we're going to fix it. And I think that's possibly a discussion for later, but I'd like to put the observation in now. Diolch, Cadeirydd.
I'd just like to reinforce that point about the cancer, cancer performance, because we have committed to 80% by the end of March, and we've seen nothing but we've stabilised a bit, but it's been a volatile year for us in terms of meeting our obligations under this. I wonder what assurance you can give to us that we will meet that figure, and if not, what are we going to do about it? Lee, I'll come to you first, and then Andrew may want to come in and respond to some of those things as well.
Yeah, thank you. I think probably Andrew best to respond to the ophthalmology cancer and probably the delayed pathways of care as well. He's smiling. So I think if I just pick up the other point that Maynard raised around the risks of the top 3, I think yes. What we're not trying to do is create a very rigid process that kind of deals with it in that way. But it does, I guess, just asking that question does cause us to reflect on what truly are the things we want to respond to. Interestingly, what's come out of that process, I would say, is actually a number of the risks span multiple CCGs. Because if you take cancer as an example, of course, a number of CCGs contribute to that pathway. So actually what we're ending up with is less a list of 3 per CCG and more a thematic analysis of the pathways that we want to look at a little differently. So so that I think has been helpful, and it allows the CCGs to think more collaboratively around what we want to prioritise and how we might make changes. But of course, the other thing to say is this is not the only process for trying to respond to those risks. We obviously have a robust governance process around responding to all the risks that we've got on the register. This is an additional way to bring all of that together at a health board level and support our annual planning process. Thank you.
Thank you, Lee. Andrew.
Yeah, okay, thank you. So 3 really important areas, and welcome the questions and opportunity just to kind of give a bit of an update in terms of where we are. So on ophthalmology and the regional working question, I think in terms of the R1 position that's reported in this paper, the regional space isn't really addressing that particular issue. The challenge we've had there is, as you'll recall, as a board, we agreed to invest some money this year in that service to improve performance. We've had a delay in terms of the recruitment processes and getting people into post to increase the capacity we need. There have been improvements, but we haven't yet had the full service up and running as we intended it to be when we brought the paper through as part of the planning process last year. So I'm expecting over the second half of this year there to be a greater level of improvement, and we've got a deep dive into that at the next Finance and Performance Committee in December. So we'll be able to provide a bit more assurance in terms of where we are with the actions in a bit more detail for colleagues then. In terms of cancer, the key issue there for us now is that to make the step change in performance, there's a couple of pathways we really need to address in terms of diagnostics and capacity. The biggest one being the urology pathway, which we know is also a very high volume pathway in terms of the number of cancers we diagnose and treat every year. The actions that we had set out that we wanted to take, we have implemented through the course of this month. I am anticipating that through December we will start to see the impact of that a bit more in our data. So I am anticipating the potential for our performance to drop a bit below 60% whilst we're addressing some of that backlog. It's not guaranteed that'll happen because it will depend on what the diagnoses are and because of the way the target's calculated. But I am anticipating we'll see a reduction through December and January of our performance. But also I would expect to see in December and January an impact on our backlog number, and that should be the backlog reducing significantly by the end of January. Once we have done that, we believe in February and March we will then get up to the next bracket of performance, if you like, which is 70 to 80%. But we think without taking those actions that we're taking at the moment, we'll never make that step change. So I think it's been frustrating that we feel like we haven't made progress from about the mid 60% this year. I suppose my reflection would be 12 months ago we were just trying to get to 60%, and we have at least managed to stabilise at that point and at a much better level. But this is a really, for me and for the team, this is a really important area and priority because we know of the impact this has on our population and the importance of early diagnosis, early intervention and early treatment on outcomes. So it's a real area of focus for us to get right, but I anticipate in the new year we'll start to see that step change in performance. And the team are telling, whilst they won't commit their colours to the mast to say we'll achieve 80%, they're not telling me it's off the table yet with some of the changes we've made. They certainly think they'll get above 70%, and they still think that there's an opportunity to get really close, if not achieve what we set out in the plan. So I just need to continue to track and monitor those actions and make sure they're having the impact that we expect them to have. And we'll start to get that feel in December. Although I know that the actions have been taken and those things are happening. I think the final area then around delayed pathway of care delays, I think, is obviously been a real area of challenge and scrutiny for us as a region. It's something Welsh Government have been picking up with us, and it's something that myself and Michael, as the Director of Social Care in Pembrokeshire, and our colleagues in Ceredigion and Carmarthenshire have been picking up as a conversation. I think we recognise, as has been commented and observed, that this does need a systemic approach to address the challenges. We had the spike in number in October has been a challenge because that took us above 250 again. The unvalidated data we've got this week from the census last week indicates that we've probably improved on that across the region by about 10% this year. So there's some positive progress. That reflects a couple of things. In part, that reflects the work from a health perspective we're doing around optimal flow and trying to make sure we are really on the case with the actions we need to drive discharge and make sure we're not putting delays in the system that make discharge more difficult. But there's still lots of us to go at in that space. But equally, it reflects actions that our partners are taking around additional capacity in the community to support discharge and placements and to help take people out of hospital. I think we started a conversation in September around how we would work differently together and commit to work differently together to tackle the challenge of winter. I think where that's very quickly gone is actually we recognise there's a real opportunity for us around a aligned sense of common purpose that could help us really make progress on urgent emergency care, prevention, demand reduction across the system, and as a consequence then the discharge pathway element of that as well. So we have got a proposal that we need to take through our integrated executive group, I think, to finalise just reviewing some of the governance arrangements and our approach to really driving improvement in this space, which we will be looking to do. we need to do that in December or January. I just need to check where it is on the kind of work programme. But there's a very real live piece of work there around how we work much more coherently together, and that does tie into some of the policy work coming out of Welsh Government around integrated community care systems, the community by design piece that the Chief Medical Officer is talking a lot about at the moment, and how we really leverage the shift and building of community capacity and response. So I think there's a few things there that are starting to come together. I don't know whether Michael may want to say something, because we both attended a meeting yesterday with the Minister for Social Care as well, where we were talking a lot around our regional response to some of these issues.
Yeah, thank you, Andrew. So as Andrew said, I attended what was called a Regional Integration Accountability meeting yesterday, the first of a number of meetings, I believe, with the Minister for Children and Social Care, and that gave us an opportunity, I think, as a system to talk about the work that we're doing in partnership to address some of these pathway of care delays. We were able to talk about recurring funding that's come into local authorities in recent times under the guise of a pathway of care delay grant. And that's allowing us across the region, or certainly in Pembrokeshire, to invest further in our domiciliary care resource, our reablement resource, and our social work assessment resource as well. What we're looking to trial in Pembrokeshire, which Welsh Government are particularly interested in, is actually base the reablement staff and the domiciliary staff within the hospital, so we can pull people out, not necessarily wait until we're being told that they're clinically optimised, pull people out earlier with a view to freeing up capacity within that acute setting. We're already en route to recruiting those staff. We believe will be fully operational by the start of the year. We've probably got about half of the dom care staff and reablement staff that we require at this point in time. The other interesting discussion that we had yesterday, which I think resonated with both Health Board colleagues and local authority colleagues, is the work that we've been doing in partnership to have the confidence, I think, to manage expectations with patients and their advocates and their families at first point of admission, that, to put it bluntly, hospitals are not a good place to hang around in once you're ready to leave. So, you know, we are obligated to work with those patients and their families, and sometimes have challenging conversations to reiterate the fact that we're not just trying to get people out to free up beds. It's for their own well-being and for their own long-term health as well. And that's something that I think we have invested time in doing in partnership, so that it's not just necessarily a health board colleague having that conversation, but a social care and health board colleague at the same time.
That is very reassuring. And I suppose I'd begin where you ended, which is, for me, there's an enormous travesty if we have 258, 59 people in beds, elderly people who shouldn't be there, you know, who are medically optimized. You know, it's such a poor way to spend that stage of your life inside a hospital bed. I can't imagine anything worse. Even though I think the staff are fantastic, it's a supportive environment, I think it's just a horrible place to be. And I think it makes older people vulnerable to all kinds of challenges around their health, around the institutionalization of their care, all the things that you've mentioned. So it's great to hear that Pembrokeshire are taking these steps. And I think the more that we can integrate and work through the same place, those services, I think the better outcome that would be. And I think we've already got a fantastic example of your social care, social worker team working through Withybush at the current time, which I've seen it. It's outstanding, you know, in terms of that work. So it feels to me this is a really positive way forward. I think for myself, and perhaps I speak for the board, what we need to be reassured about is that there's no complacence inside this space, that we are doing our utmost and level best to try and make the, you know, to kind of take us to a place in this in resolving this issue where everybody, and most importantly patients, are discharged and receiving the appropriate care they need to live healthy, happy, successful lives within their communities. So I think that is the most important thing for us. But thank you for the update. That's reassuring. Michael.
I just want to echo what the Chair's just said there, because I was going to ask Andrew about whether there was a kind of a bit of a structure to his discussions with the partners and stuff like that. And then, of course, he then answers the question. And then what the colleague said, Michael said there, was again very, very reassuring. So I just wonder, though, like on what you said, Chair, how do we as a board, without getting into the operational reads, how do we get a kind of line of sight on what sounds like really good initiatives and how that is translating, how that can be rolled across the regions? Because it's such an important point. I mean, so I say, where does that filter up into committee or board so we don't lose this sudden initiative or what the knowledge we've just gained in the last few minutes? Yeah.
Yes. And building on that, whilst our role is assurance at one level, to be assured it's right, there's also something about what are we contributing as a board to this process? What can we do to support the endeavours of staff within the health board, but also the local authority to be able to discharge this well? A good question.
So I might start, and Michael may want to come in as well on this. There might be others around the table that are in that space that would like to comment. So I think one of the things that I suppose one of the things we've picked up from other regions is of best practice or things that are going well are that other regions have established some kind of memorandum of understanding, which is this kind of sense of shared purpose and commitment around what we're all going to do in this space. So I think we're really committed, and we've all said that we want to develop that and bring that through the RPB space in the new year. I think what that enables us to do is that enables us in terms of some of the space where we do get money, whether that's recurrent or non-recurrent. So things like the Region Integration Fund that we've had, it enables us to be really purposeful and be really clear on the intent with which we're making joint decisions on how we utilise resources we've got available to us to have an impact on this broader agenda. Because the agenda, I think we've got to be really careful of is this agenda has to be much more than just pathway of care delays. Pathway of care delays is the high level metric that from a health board we get challenged on a lot by Welsh Government, but actually the real opportunity for us in this space is how we have a real shared almost commitment around a set of outcomes that support the agenda around prevention and the agenda around keeping people at home and looking after them as close to home as possible and managing demand. And I think that is where we will get the real strong level engagement and sign up across the system to make a difference. The impact of that will be the reduced demand will mean we end up with less delays in a period of time. So it's a challenge. I think it's a challenging conversation because the focus and scrutiny is often on a particular area, but the real benefit I think we need to drive is in a slightly different space. But by coming together, we can do both, I think, and speak to the needs and objectives of all the organisations and partners involved.
Thank you. Back to your question, which is how does it feed through to us in terms of our assurance? I think we should take that away and think about that a bit more, Michael, because I don't think it's easily answered as a question. We might want to explore that as a development issue to make sure that we feel that we are fully sighted on this without needing to get into the detail of it, as you suggest. Joe?
Yeah, I was just going to add, Chair, that we do talk slightly about this in strategy and planning as well, but also the partnership report on board, which maybe we need to think about where that sits, but we can look at the governance in general, and we did have an MOU for RIF funding, so it could be something that we can then widen. What I would ask is that we put pace behind that, because that's been exceptionally difficult to get that MOU in place.
Well, there we are, an instruction from the Board Secretary. I think we'll take that on board. Great, okay, let's take a few more comments and then we'll close the item. Michael, I'm going to come to you, and then you, and I'll come to you.
Yeah, thank you, Chair. And just on the back of Andrew's comments, I think we've acknowledged that we need to meet as a partnership in order to learn, not in order to challenge each other in a reductive sense about each pathway of care delay code. I think we've come a long way actually as health and care systems. I remember being in meetings in a previous organisation where you would literally go down the codes and you were told, this is social care, this is health, and you'd find the majority of them were in another code because the reality was there were whole system issues. And that felt quite attritional. So I think we've acknowledged, Andrew and myself, that we need to meet as a learning system, whilst at the same time taking all the data that we've got to identify possibly 2 or 3 pain points that we want to make a really good go at trying to affect positively in between the meetings. So, for example, that could be social care assessment, it could be nursing assessments, it could be the ability to secure a care and support package, because sometimes this can just feel too big an issue to contend with. I also agree with Andrew's point, though, that we're determined not to meet up just to talk about pathway of care delays, because actually, and it comes back to the wider kind of health strategy, we should be in the business of increasing community capacity as well and shifting left. And if we do all of that right, this will become less of an issue over time. But that's actually trying to shift the resources and the mindset and the energy towards that area. That can often be the challenge, but we know that's where we need to focus.
I think that's very, very helpful because I look at the delayed discharges regularly, weekly, and as I look at the list, I'm thinking, who am I going to blame? And I'm thinking that's not the right approach here. We need, just as you've indicated, we need a systems approach that says let's work towards a shared common agenda where we can collectively and in an integrated way solve this problem, as opposed to just find the deficit in the current system and try and resolve it that way. So I think that is very reassuring, and I'm confident that I think that would lead to a much more positive outcome. We've got lots to learn in that space, which feels the best opportunity. Yuan.
Diolch, Cadeirydd. Yeah, totally support in terms of what Andrew and Michael have been kind of articulating around we need a joined up kind of approach in terms of looking at those pathways. Whilst we can talk about it strategically here, I think we need to remember for our population in terms of making it as simple as possible for them in terms of understanding what they can get, what's on offer, and how that's applied to enable them to be in their own homes rather than in hospital. And again, you know, I welcome in terms of Michael's kind of point there around the community aspect. And colleagues will know, you know, I constantly try and just kind of focus us sometimes to look back from that community angle. And in terms of the community input into it, and again, with thanks to Michael, particularly in Pembrokeshire, for the support that we've had from the local authority and the health board in terms of the community input into looking at people being discharged and the prevention. It was mentioned, you know, in terms of getting numbers. Within the kind of community angle on the Catalyst for Care programme, which I know we've referenced at this board before, the latest data that we've had through just for the last 12 months is that at the moment, the community support is providing 3,733 hours of care per week to take the pressure off our statutory partners. 1,007 clients across the Hywel Dda region are being enabled to stay in their own homes thanks to that community support. But only 85 people have actually been supported home from our 4 general hospitals in that last year. So I think there's a little bit more work to do in terms of engaging with our partners based in these kind of coalesced teams to look at the alternative options, to take the pressure off our statutory services, but to enable a community response to really have that powerful impact. But the data is certainly showing, you know, 3,733 hours in 24-25, whereas last year it was 2,800 hours. So there's a real community initiative there to work in partnership to be part of the solution.
Very helpful. I think we should be completely data-driven on this. So I think you're absolutely right. Very helpful, Yuan. Sharon, and then I'm going to close the item.
Thank you, Chair. I was just reflecting on the question that Michael asked and going back to your opening statement around the impact this was having on patients and the risks associated with being in hospital and the hospital-acquired conditions that can occur when you're in hospital too long. And just reflecting on the comments there that you made, Ewan, about the data as well, I think in addition to strategic planning, there's a role for Quality Safety Experience Committee as well to sort of look at the impact on patient experience, look at the impact on deconditioning, and to feed that into all, so we triangulate all that information and communicate that better. Yeah.
Very helpful. Thank you. I think Chantal has a question.
Yeah, Chantal's just messaged in relation to the planning cycle update. I wonder if Lee can clarify what he means by this approach, as in my mind it might lock the organisation into the current plateau and how it aligns with managing potential underperformance.
There's a question and a half.
Sorry. You might need to repeat that again, isn't it?
So, in relation to the planning cycle update,
Yeah.
I wonder if Lee can clarify what he means by this approach, as in my mind it might lock the organisation into the current plateau and how it aligns with managing potential underperformance.
Yeah, so the planning cycle is obviously our pattern of assessing where we are in delivery against this year's plan, what we think the key risks and opportunities are going forward, and then developing responses to those. So that's all. That's, I guess, all that's meant by the sort of phrase of the planning cycle, in order to produce a plan. I guess. Probably in the way I described it earlier, I think it's recognising Chantal's point that if we continue to repeat, broadly speaking, the pattern that we've been following over the recent years and previously, we won't see a significant improvement in our risk profile. So if that's, I guess if that's the point that Chantal's referring to in terms of a plateau, I think that's absolutely correct. That is the challenge that we face. So we're going to need, as I indicated, I guess, in my introduction, we're going to need to make some step changes in certain areas, and that will require some quite significant decisions in order for us to break out of that pattern and continue on a trajectory to improvement. That with that comes lots of challenges, which we obviously know, and I'm sure we'll come back to later in the conversations. But I suppose I probably agree with the thrust of Chantal's point, and that's a challenge for us as a board as we go through the coming months.
So great. I'm going to close the item, but in fact, Chantal's question was probably better articulated than the question in my head, which is, how do we know it's working? Just the whole nature around planning, getting the organisation to be more disciplined in terms of what it intends to do. How do we know that our approach is the right approach and we're getting the best outcome? And I'm not expecting you, Lee, to answer that, but I think it's a really question we need to hold on to as we think about what's the best way to plan across this organisation. Because last year, we changed our approach to planning. It was rigorous and it was disciplined and it was well in advance of the performance year, which I think is a great way to plan. But the question that we consistently need to ask ourselves is this making a difference? Do we see the value of this plan in terms of improved performance, improved care, better management of resources, all those broad questions? I'm not going to expect you to answer it, but we can return to it perhaps at some time in the future.
Yeah, I will just make one point. We do obviously undertake a self-assessment of our planning maturity. Obviously, we've taken that through committees and so on. So it is a question we're constantly asking ourselves, because you never get to a good process effectively, do you? You need to iterate and improve constantly.
Of course you do.
So I think it is an absolutely valid question for us.
Okay, so Winston, perhaps to be taken back to strategy and planning, that question, and to think about that in the future. Thank you very much for that. That's been a helpful discussion. I'm conscious we're veered towards delayed discharge, delayed cares discharge, but the broader thrust of it, I think we're comfortable with, and the approach that we're taking. So, can we take assurance from the update on progress against the planning cycle? Is the board comfortable to do that? Great, okay. Can I then move us on to our next item, which is financial report? Hugh.
Diolch, Cadeirydd. Report is outlined there for members. I'll just pull out some of the highlights for this month. So the position in month 7 does represent an improvement for us, but there are also very clear structural challenges and a clear reflection of the unsustainability of the delivery trajectory we're on this year as we veer towards thinking about next year's plan, to make the link back to Lee's paper. In month 7, the position reported is a 0.6 million deficit versus the 2.5 million plan deficit we had for this month. There are a couple of very significant one-off impacts within that. The first is a one-off accounting gain, which relates to a system issue and an error in the flows that happened from a clinical system WellSky is used within our aseptic units through to the financial consequences of that. And effectively what happened is that since the system was implemented in 2023, we have double charged our income and expenditure account for drugs issued, which has built up a balance on the balance sheet, which has now been recognised. We've recognised that error and issue, and we've released that into the position, so it's given us a one-off benefit. Chair, just for the board's assurance, we are doing a full review of the root causes of that issue, and I've also asked for support from internal audit to understand what learning there could be in terms of system implementation approach across the health board where clinical systems interact with financial consequences. So we will get to the bottom of making sure that that isn't repeated. We did pick that issue up through our standard review of the balance sheet. It was starting to, if you like, glow red in terms of the impact that was having, but we need to recalibrate that review so it's much more sensitive to picking up those issues earlier. So that's the first issue. And the second issue to highlight then is that we've recognised the Welsh Risk Pool risk share arrangement across Wales. Now this relates to historic cases of clinical negligence that have resulted in charges into the National Welsh Risk Pool. Because the court service is increasing the number of slots available for cases, that means that there is an increase in activity going through the court system and settlements are being reached quicker. Now that is good news for those people who have been adversely affected by care historically, but of course it does have an impact on our position this year, and that's 4.2 million. That's offset that one-off gain. There are clearly operational pressures and challenges that we're managing as part of that, particularly around premium medical agency, continuing healthcare, particularly within mental health, theatre activity, as we are increasing our recovery activity across the health board as well. Our improved position does mean that we can improve on our forecast, and I'm recommending that we improve our forecast from our position in month 6 to 24.1 million as our baseline position, plus the recognition of the Welsh Risk Pool. So on that basis, we will be at 28.3 million, which as a headline number looks like a deterioration from month 6, but of course it does recognise the inclusion of the Welsh Risk Pool position. That isn't without risk. Clearly we're heading towards winter, and we have seen some deterioration in operational forecasts that are coming through, but if we maintain on our current run rate, it is an achievable position for us as a health board. Savings delivery is better than plan across the organisation, but it is overly reliant on non-recurrent delivery. And I'm particularly grateful to colleagues, particularly within corporate services, for taking decisions to delay and defer cost pressures where that has been possible. As always, I'm grateful to colleagues across the organisation who've been able to realise some of those non-recurrent gains, and that they have been hard won. Because it has been through robust cost control measures that we've been able to put those in place. But it does highlight the continued challenge we've got in translating good cost control, which has become an increasing part of our armoury, into real operational and clinical change that then makes those benefits sustainable. So on the basis of our over-reliance on non-recurrent measures, our underlying deficit has deteriorated this year to now about 62 million, and that's something that we will need to pick up through our plan. Our cash position, as always at this time of year, we need to request support from Welsh Government to sustain the deficit cash that we are carrying, and I've outlined in the paper a letter for approval which will be submitted from Chief Executive to the Director General for strategic cash support. I've outlined the areas of support that we need, or focus and actions that we need to take as an organisation. In particular, while we gain traction over recurrent actions, it is important that we maintain that focus on good cost control for the rest of this year. Our recurrent delivery is a priority, and that does mean that while we have got some assurance now over our position this year, we do need to pivot quite urgently to focusing on next year and focusing on our underlying position. And I'll come on to that in more detail on the next paper on our 3-year recovery plan. And lastly, I do want to also thank Jill for your support, Jill, in the financial agenda. I know from when I first started as a relatively young whippersnapper, you knocked me into shape, and grateful for your support in that agenda during my time here. Thank you.
Thank you, Hugh. Very helpful. Colleagues, questions? Okay, so let's try not to try not to mix up these two papers. This paper about the current status quo, and the next paper, which is very much about how we're going to get to a sustainable position in the future. Michael first, and then I'm going to come to Winston, and then Sarah, and then Maynard.
Just Hugh, just in the report I'll give a bit later on the F&P committee, we looked and we discussed how we are looking at savings, and we say about how looking at what's being presented to us presented to you and your team about savings is a robust process. But then in this document we then say, and this is honest and transparent, you say a proactive approach to declaring savings has not yet materialised. So therefore, although we can kind of looking at what we've got in front of us, so that seems to me to be saying when something's put in front of us, we've got a good way of examining it, scrutinising it, but we want more stuff put in front of us, kind of thing. So how do we square that circle is my question, particularly as we're already running out of this financial year already, and setting a good foundation for the next paper going forward.
Helpful. Thank you, Michael. So, Winston.
Yeah. Hello, can you hear me? Great. So I think, as a commentary, I think this paper has got a number of mixed messages in there. On the positive front, as a health board, we're achieving our required target for the plan, and I think it's worthwhile reflecting as a health board that it's not been an easy journey for us. We've had to go through and look at in-year schemes to get there, and whilst Hugh's described earlier the change into accounting, which has meant a gain of £6.1 million, in many ways I'm pleased that we've identified that now rather than later on in the year, because it's given us a degree of headroom. I guess my underlying question is one of this report talks more about what was spent. I'd like to know where the opportunities for preventive measures can be going forward, because it seems to me that we've done our level best to keep costs under control quite well. We've done our level best to identify in-year things, and I think it gives us headroom for this year that we're going to achieve our target. But let's make use in the remaining months of the year towards identifying the gap that we've got in our recurrent savings targets, but also where the opportunities are. Because I think it's commendable to Hugh and the operational divisions as to where we've got to so far. But I'm sorry, this is a bit of commentary, but I'm also worried that we've got here through curtailing our corporate services, who are ahead of their short-term plans in terms of performance, but our sort of clinical care groups have not identified and delivered. So I'm kind of worried about that kind of mixture as an organisation, and how we're going to manage that from now until the end of the year. It's a bit of a long rambling commentary and question, but
yes, you're articulating what I think a number of us are concerned about, which is the unsustainability of this process. Thank you. Even though I think you are right, we've made good progress. The question is about our sustainability. Thank you, Winston. Sarah.
Thank you, Chair. So I think this follows on from what Winston was saying. I'd really like to understand what is happening where the CCGs are either not able to identify their savings or where we know that they're being overly reliant on the non-reoccurring savings. How are we supporting them to think differently about what they need to do? How are we supporting them to be more proactive? What's the accountability around this? What's the assurance that the CCGs have a real grip on the savings that need to be brought to the table, particularly the non-reoccurrent savings?
Okay, I'm going to take some more questions here if you're happy with that, and then Maynard, and then I'm going to come to Ardiana and then Eleanor.
Thank you, Chair. Very quickly, Welsh Risk Pool. Conscious that this is an all Wales issue in terms of delivery of this, and I was just wondering whether there are any conversations going on with Welsh Government about supporting that, because at the end of the day, it will hit our bottom line if there is no support, and likewise the other health boards. Second question is not an area we've picked up in this particular report, but previously the healthcare support workers issue, the band 2-3 issue, has been ongoing for quite some time, and I know that we've budgeted for it in our totals. Welsh Government last week announced a settlement in that area, and I was just wondering whether Welsh Government are putting any additional funds in to support that settlement, or whether we have to find it, which is not a particular issue for us because it's budgeted for. But just wondering, as it's an all-Wales settlement, whether there is any national support for that as well.
Thank you, Maynard. Ardiana.
Diolch, Cardid. In response, very briefly to Winston's remark, very rightly so, on how we're going to ensure in next year and going forward that we focus more on prevention. I won't elaborate too much because we'll have the annual report of Director of Public Health which focuses on this. But I'll just state that through the planning for this financial year, we did agree as executive and through the board the investment and a shift of some of the resources to the health coaching service, which is very preventative-based delivery. It wasn't affordable to do it fully in this year, but we will start this year and will expand as we go into the next financial year. We're also working on scoping and developing, potentially for the next year, further services in community, as Andrew has already referred to, both with asset-based community development with our local authorities, but also in a service of community health and well-being workers, which will focus in our most deprived areas, working with communities and individuals that are at the highest need, that do that very, very first line of prevention, but also through the pathway, including, as we discussed earlier, discharges and support of people to come out and stay with a greater level of fitness in their communities. Also progress with healthy weight, the whole system approach with our PSBs. All of our 3 public service boards have agreed and are working towards prioritising access to food as part of the healthy weight. Thank you. Jill.
Thank you, Ardiana. I mean, I think we've already had conversations this morning about how all these things are connected. They are fundamentally connected, and this is about our long-term commitment to prevention, which we have to grip. And I feel as if we're catching bits of it, but we haven't really yet made that commitment because we're not. Well, for all kinds of reasons. I'm not going to diagnose why not. But the reality is, we absolutely have to make that change in the long term. Yes, please, Eleanor.
Diolch, Cadeirydd. You have virtually made my point for me, but I could not look at this paper in isolation from several other papers because of the systems issues involved. The point made in this paper, we have to have a fundamental change in the way that we're going to make cost savings. And it made me think about the Public Health Director's report later on, the fact that caring for people in communities is less expensive than it is in secondary care, the fact that we really need to, and I hate this phrase, the shift left, we really need to be able to move to a more preventative and social model of healthcare to be sustainable going forward. This analyses where we've got to now, and you know, well done to him and the team for pulling it together. It's not without actually a lot of cost and well-being and things for our staff doing it as well. And I really want to recognise that. It's a huge effort. This is now, but we can't, somehow we've got to get into that shift sooner rather than later to be sustainable.
Great, very helpful. Okay, Hugh, there's a whole list of stuff there. I'm going to hand over to you. Andrew, so let's come to Hugh, and if there's anything you want to add, Andrew, we can...
I'll be able to help him.
Okay.
I'm relieved. Thank you. So if I start off with Michael's question around the process we've got and the recognition of the proactive comment there, that recognises that part of what we've done this year in order to gain more assurance over our position is where there is an underspend realised in any particular month, we sweep that out as a saving. So that means that there is not a year-to-date underspend that can then be spent in the second half of the year. So it's a process of gaining grip and control over the decision-making we've got going on within the organisation. The challenge with that then and converting that swept underspend as a saving into a recurrent saving is what I'm expressing in that need and desire for us to become much more proactive in our forward look. So it's not necessarily a reflection of lack of ideas coming through at this stage. It's more reflection of that process that we've got going on. Winston talked about the positive news coming through the report. I do want to re-emphasise that, yes, that is a favourable position for us, but it isn't without risk. And it's incumbent on us. We're still only halfway through the year, just over halfway through the year. There's a lot that can happen in the second half, and we need to maintain a focus on the risks that we've got coming through. There are absolutely opportunities for us to think about how we step change our approach to prevention. We approach our services too frequently, especially from a financial perspective, as a provider, not as a population health system. And I think that is something we do need to recognise. We do have some time now, though, given where we are with this financial year, to not be looking at remedial actions that we need to deliver in the immediacy of the next few months, but actions that need to shift the system going into next year. And that's something I do want to make sure is landed with the board, that we do need to now reflect on changing our system to sustain it. Sarah, you mentioned the issue within clinical care groups and I guess the assurance that we've got over the processes within clinical care groups. I think increasingly this year we've seen a maturity in cost control within clinical care groups. We set up the financial control subgroup some time ago now, it must be over a year ago now. And at the start of our central process there were a number of cases that would come for recruitment that we would challenge, ask questions, and we weren't assured over, and therefore we weren't proceeding with recruitment. Increasingly throughout this year, those challenges are becoming fewer and fewer, which demonstrates an increasing control and understanding from clinical care groups over their role in maintaining good cost control. And so the cases that are coming through are much more robust, which is really positive. The challenge we've got now is less to do with cost control and more to do with system change, which re-emphasises the point that I just made. Maynard, in terms of your question on the Welsh risk pool and the band 2 to 3, I'll take both together. There is clearly an ongoing discussion with Welsh Government. These are issues that are consistent across Wales, and funding discussions for that are something that I know Welsh Government are very conscious of. I've got nothing to add to what's in the report at this stage. Clearly, if there is any funding arrangement that is reached for band 2 to 3, that is something that's already within our position, and therefore that would be a benefit to us. And given we've now also recognised the Welsh Risk Pool position, that would also be a benefit. I would say that the Welsh Risk Pool is still subject to risk in that there are some material cases that, depending on when court settlement happens, could increase the position for us this year, and that's still very much an ongoing discussion with colleagues centrally in shared services. And Eleanor, lastly, in terms of a change in approach, I guess, to cost savings, there are three elements of efficiency. If I get a bit nerdy here for a minute, technical efficiency, where we do more with less. And I think we are, through good cost control, we are doing what we can within that technical efficiency lens, but it still looks at our services as a provider of services. Then we get into allocative efficiency. So how do we allocate resources in the most efficient way? And I think there are two things we need to reflect on there. Shifting resources from low value activity to high value activity, and shifting resources from low risk activity to addressing high risk activity, which comes back to what Lee was talking about earlier in terms of our approach to our planning cycle next year. And that's not to say anything then about personalised efficiency, where we are affecting the outcomes that individuals are receiving from our services, and there's a long way to go in that space as well. Those are areas that I think we need to increasingly address as a board, because the technical efficiency space, while there's more we can do, is not going to be sufficient in and of itself in the future.
Which kind of leads us to the next paper, in many senses, and what we should be thinking about more broadly. Okay, Andrew, do you want to say anything?
I suppose just a couple of things, because there might be a couple of points I'll make that might be more relevant to the next paper anyway, because it's kind of a bit of a grey area for me here in terms of some of the questions and where we go next. I think I suppose just a couple of things I want to say. I think one of the things we probably don't recognise, and I need to work out how we bring it through better, is within the service space and the operational space, there are significant risks being managed and service deficits being managed in terms of delivery. So if I take as an example one of the CCGs, so allied health professionals and health sciences, they will, when you go through the report, that will point out that they've not delivered any savings this year. If they hadn't taken some of the actions they've taken, they would be £13 million overspent. They've managed a £10 million risk so far. The 3 million savings target is something that when we've looked at, we don't believe as a collective that they can deliver that without having a detrimental impact on their service delivery. If I look at what we've done over the last 2 or 3 years in looking at how we generate savings through those CCGs that aren't hitting the targets for savings delivery, we have done numerous impact assessments and quality impact assessments and reviews against core service frameworks that indicate to go further than we're already going with them, will have a further detrimental impact on the service we could offer to our population. So I think there's a real leadership challenge there for us in the board space around how we support services to kind of work through those challenges. Some of the issue we've got is that a lot of it is around we're trying to deliver something in year, and some of the timeframes for delivering the scale of transformation and change that we need to deliver will take longer than 12 months, and we'll come to that. I also think there are some challenges there in variable pay is a significant challenge for us. We've done a lot of work on nursing variable pay as an example over the last 2 or 3 years, and that's having a positive impact in stabilising our workforce, stabilising some of our services, but also addressing some of our cost. Medical variable pay is something we'll often talk about, but we need to, and this might come out in the conversation later on this afternoon, a lot of our medical variable pay cost isn't actually, it's wasteful in the sense of we could get better value for it if we used it differently and recruited differently against it. But actually it's covering some fundamental service gaps. So we don't have many rotas that have prospective cover in the medical space. So the minute somebody's on leave or off, we have to use agency or locum or additional shifts, ad hoc shifts to cover them. So there's some real structural challenges there that we need to work through that also tie back into some of the stuff we'll talk about in the next paper around our service model, our service configuration, how we become more efficient. I think the last thing I wanted to say then, which starts to move us into the next paper so we can get onto that, is we talked earlier on around the contribution Jill's made in her role, and I think the greatest gift and legacy that Jill is leaving us is the fantastic work she's done in developing the leadership capability in primary care. And I think in part of my thought process at the moment in working out how I live in a world without Jill here is how I really maximise that legacy that she's handing over to me, and we use that capability and leadership potential to really shift our thinking, move to the preventative space. But also, I think that really gets us into the high value, low value conversation as well in a different way, allows us to look at things on a pathway basis, a population need basis, allows us to be really clinically led, and just helps us address some of those fundamental challenges that will benefit our population.
Okay, great. I'm going to close the item there. I just say you might want to say something, but we'll do it in relation to the next item.
Yeah.
Thank you, Andrew. I mean, and thank you for the explanation in terms of clinical care group kind of cost savings, and where, in response to Sarah's question, where our anxiety kind of clusters around those parts of the organisation that are not delivering their required cost saving. And your clarity on that is very helpful, and indicating the fact there's a tremendous amount of work taking place in that space. It's just not reaching where we need it to reach, which then kind of, I think, from my perspective, takes us further down that road of saying we fundamentally need to rethink the paradigm of many of these services in terms of how they're being delivered on the basis they're never going to. I've said it before in this board, we cannot continue to cut the cloth. It just gets smaller and smaller. We have to find fundamental ways to rethink the kind of service paradigm, and then look at the funding, which is enabling that to become much more sustainable over that period as well. So I think that drives us further down that gap. I'm going to close this item just by noting a number of issues and receiving assurance before we move into our next item. Can we recognise first and foremost as a board our financial position in terms of the 4.2 kind of potential costs that we're going to incur in relation to the risk pool, and also how that will impact upon our total deficit of 28.3. Can we just acknowledge that? Okay. Recognise that the forecast deficit will be updated if further recognition of the Welsh risk pool is required. So if that figure changes, then we're going to have to acknowledge that as well. Seek assurance. Are we assured on the progress of savings that we've seen to bridge that recurrent and non-recurrent savings gap? In part. We are reassured in terms of the explanation you've given. Does that remove our anxiety around this? No, it doesn't by any means. So you've reassured us in terms of some of the process of that, Hugh. I think we're still anxious about the unsustainability of that as we move forward. We note that the Amber Saving scheme judgment around future run rate and those issues. Conversion totalling 3 million has been included within the month 7 position. We acknowledge that an underlying deficit assessment has been undertaken, and that will only be reduced by robust recurrent savings delivery improvements, all the things we've just said. Can I ask that we approve the draft accountable officer letter, which the Chief Executive will need to surrender to Welsh Government, and note the work that is ongoing to provide more insightful and relevant reporting through the financial performance report development. Thank you. Okay. Right, what stands between us and a coffee break is this next item. So that's not to suggest we don't attend to it appropriately. It's just let's be very focused and clear about what it is we need from this item. So Hugh, I'm going to hand back to you.
Diolch, Cadeirydd. colleagues will know that I really don't like the phrase finance roadmap. I don't like the phrase roadmap because the map keeps changing, the starting point keeps moving, and the car is probably always changing as well. So it's not a particularly helpful phrase. But this is a first iteration of a 3-year plan to 28-29. Delivering or developing a credible 3-year plan is a challenge given the uncertainty we've got in our income assumptions. That's always been a challenge for us, but it's a particular challenge for us at this point in time, given that there is an election and we're in that stage in a political cycle. Quite an understandable challenge, but nonetheless, I want to emphasise that clearly there is a very material set of assumptions that get made on the basis of anticipated income. We've taken a different approach to developing this 3-year plan, or these sets of 3-year models, in that we have costed the impact of prevalence, disease prevalence and growth in our population. It's not something we've done in the past. In fact, what we've done is recognise demand after it's occurred, rather than prospectively recognise that demand. So we have recognised that in all 3 scenarios that I'm setting out here in the plan. I've set out 3 scenarios, Chair. The first is a baseline scenario based on funding which was anticipated per the UK Chancellor's spending review assumptions. Now, UK spending assumptions may not translate into appropriate assumptions for this health board. Clearly, Welsh Government has its own decision-making process, quite rightly, and therefore we may not expect all of that to flow through. But on the baseline assumption, break-even would be achievable in year 2, and that is a requirement for us per the contingent funding that was provided by Welsh Government last year. But it is heavily dependent on continuing to deliver a degree of non-recurrent measures in the early stages of that plan, while recurrent measures then pick up latterly. The second scenario we've got is a zero uplift scenario. Now, that's broadly the position we're in at this stage in terms of the intelligence we have on what's likely to come our way. We haven't got confirmation of that. That will follow in December, but that's broadly the scale of the challenge we're facing in that space, certainly for year 1, which may change post-election. And then lastly, the third scenario is effectively a continuation of this year's funding settlement, which was 1.77% uplift. And on that basis, it doesn't close the gap we've got to achieve a break-even position. Now, this is just a financial modelling assessment. It doesn't necessarily hit the road in terms of delivery within the organisation. And there are a number of concerns in that space. We've already talked about the need for system change that would support the delivery of recurrent measures. But I'm also conscious of, if you like, the psychological impact on the organisation of continuing to deliver a degree of non-recurrent savings and the sustainability of that continuation when we know, as Andrew's alluded to, there are, in many ways, hidden deficits within the organisation in terms of the services that we're providing. So it does require that continued cost control over that 3-year period, which I recognise will be challenging. Certainly transactional savings won't get us there, because we're talking about here a quantum of saving that is more than we've delivered this year, at 50 million a year broadly, which is a very significant challenge for the organisation. But I would say that on the basis we've included in our cost pressures disease prevalence, any activity we do in a proactive, preventative care space does provide us with some headroom in what that could avoid in our position as a cost pressure. It does need us to think about prevention across a number of timelines, though, not just the long-term prevention, but also focusing on what short-term prevention can do, what secondary prevention could achieve to reduce demand on our services. This is based on a detailed plan of potentially achievable savings opportunities that has been socialised with executive colleagues and has been to our Finance and Performance Committee, but I've not brought it here just for the sake of the quantum of paper that would entail. Chair, I'm not asking for approval today. This is just to note. This is to consider the realism of the challenge that we're facing ahead of us in order to achieve sustainability, and recognise that we will be building on this as part of our planning framework, as Lee's already spoken about.
Diolch, Hugh. Very helpful. Do you want to say something before we...
Yeah, can do. Yeah, thanks. So, yeah, diolch, Hugh. So I think that does vividly describe the kind of challenge that we're facing, which I think is helpful for us as a board just to face that now. It is remarkable, I think, what we've achieved over the last couple of years. When you look at the situation we were in, about 2 years ago, the fact that we could start planning for this year at about this point last year, the fact that we can do that confidently, we can spend time on that as a board, as an exec team, as an organisation at this point in the year, I think is very, very significant and important given the challenges we face ahead of us. I think the budgetary control and accountability that we put in the organisation is still going to be necessary, but we can see that it's not going to be sufficient. I think that's what it's all pointing to. So all the work that we do on prevention, on health promotion, on the community by design work, that's being progressed nationally, but our version of that as we build that capacity in our community and primary care teams, because we're going to need to look at really how big the hospital's sort of functions need to be, because some of it is going to need to be in community, and we need to build the capability and capacity in community to do that. There will also be a challenge around the fact our services are very spread, and I think there is an issue around the people. Lee talked about unseen deficit, others have talked about hidden deficit. There is a significant issue with that our staff are managing every day, because they're trying to run services in a very creative way that other health organisations wouldn't have to do, because they're all kind of in one place. So, and we've got, our communities are widespread, and we need to obviously take that into consideration, because we've always been thoughtful about where our communities are located and the travel that people have. But, this is going to be a big challenge for us. The other thing, looking at the kind of allocation that we have, we're not going to be able to do a lot of double running. That's also a challenge for us, because sometimes the kind of ideas that come forwards need double running. Well, we're going to have to think carefully, be really specific where we do that. But I would say, broadly though, when organisations are faced with challenges like this, it's the time when they're most creative and most transformational. So I think that gives us hope, and I do believe our primary care clinicians we've talked about want to be a significant part of the leadership of this. I think you will hear from clinicians and managers later today where you'll hear that they are up for change and transformation improvement. So I think we build there from quite a strong foundation. But yeah, I think, we're in a good position in the sense that at this point in the year we're starting to think about this. So we've got quite a lot of months to put our plan in place, albeit we don't have all the information on the allocation.
Very helpful. I think that going back to the last conversation we had, Andrew, where we need a shift, a seismic, paradigmatic shift in the way in which we think about our services and how we deliver them. And we fundamentally have to be really courageous inside this space, because it's an unpopular road. It's an unpopular road. The accusation we get levelled at us every time we try to change or alter services, you're just saving money. You're just saving money. And in reality, my response is, no, we're making sure that the money we have, we spend to best possible effect and to the best possible health outcome. And somehow we have to sustain and create that narrative. These things will not be popular, but we cannot go on being a hostage to the fortune of medical agencies that cost us enormous amounts of money, immorally cost us enormous amounts of money for the services that we're trying to deliver, which are often not as optimal as we would want them to be. We have to be brave inside this space and do things very differently. And we very much have to think much more about the preventative agenda. We will never, satiate this demand unless we do something about the demand that's placed upon these services, and that we work with our local authorities and our communities very differently about how we manage that in the future and sustain that healthy population instead of thinking our role is just to cure it as opposed to prevent it. So, good paper, very thought-provoking and very challenging in terms of how we think about this. Colleagues, any thoughts before we... Yes, please, Maynard. Sarah.
Thank you, Chair. I have a question, but it's a relatively minor question. But one of the things that we don't talk about, because this is concerned about our revenue side of things, is our estate backlog as well. And I think that contributes to our ability to transform services. Some of the places that our staff deliver services in are totally unacceptable. We have a 300 million plus estates backlog. And with that backlog in place, I think the work that our staff do is absolutely incredible. And I'd like to thank them for that publicly, because they constantly come up with new ways of doing things within unsuitable premises. And I think if we can start to address some of the estates backlog, we also empower them to actually do some more transformational work, because so much of the transformation comes from the bottom up. The specific question I have is, Hugh in his earlier paper mentioned that some areas are delaying and deferring costs. I'm just wondering how much that contributes to our cost pressures for the coming year.
Helpful. Okay, Hugh, I'm going to ask for and then we'll close the item. I'm very mindful, Winston Churchill said, we shape our buildings, thereafter they shape us. And there is something about the fact that we navigate and we grow ourselves around often suboptimal estate, which isn't good for staff, it isn't good for delivering excellent services, doesn't help morale, doesn't help people feel valued inside that space. So we acknowledge that, notwithstanding the challenge of trying to do something about it, Maynard. Sarah, and then Winston.
Thank you, Chair. At the risk of stating the obvious, we are operating in an unsustainable system. We hear it every day on the ground, we hear it in papers from Hugh. We are unsustainable. And I think the requirement for a seismic shift now is the clarion call, Hugh, to making that happen. I think we tend to consider fragmented parts of our system. We see papers on UEC, we hear papers on primary care. Fundamentally, what is the shape of a sustainable system for West Wales? Because we don't have it right now. What does that look like? And I think that's a challenge that we really need to rise to quickly to understand what that looks like and then work out how the heck we deliver it.
Helpful. In that kind of unhelpful kind of way.
In an honest way.
Yes. I think you're right. And I think that feeds through to our strategy work, to be honest, and the future of what we think we're trying to deliver. Yes, please, Winston.
Yes, some thoughts. So you've kind of stole a bit of my thunder. So I'm thinking alongside this has to be our primary care strategy, how we're going to move from analogue to digital services and the opportunities in using AI and things. So what we've set out here is what the challenge looks like, but what we need to start to say is about how we go about addressing that challenge. So, what if we stepped up our prevention measures, if we stepped up what we're doing about value-based healthcare, and if we started to invest wisely some of the areas that we've talked about, maybe that's to do with risk or maybe that's the opportunities for the future. I think that's, so here at the moment we've just really set out, if you like, it's a kind of holding position, isn't it? But what we actually need to do is to create and craft what the services can look like, acknowledging your point that it's an unsustainable system, but saying in an unsustainable system, what's the best we could get to by the end of 3 years, I think. So it's more and more common. I think it's good that we've set it out, actually. It's better to know than not to know. And then it just sets a challenge for us, a challenge or an exciting opportunity to do things differently.
Well, I think we knew anyway. I'm not convinced we've been honest with ourselves.
Oh, there's one more point, is in terms of the workforce side of things as well, because we can't do what we're doing without our workforce. So there's some thinking to be had about what does the shape of our future workforce look like. Do we have the same amount of admin staff, or do we actually get into the space of a creative, different way of delivering health services?
Great, okay. Thank you, Winston. Hugh, I'm going to come to you.
Yeah, thank you, and thanks for the questions. If I start off reflecting on Maynard's point around estate backlog, absolutely, we know we've got a challenge, and NHS, the Health Foundation, has written a report recently on productivity in the NHS, and capital is one of the areas that they have acknowledged is a really important driver of system productivity. I want to be very clear. When I talk about productivity, I'm not talking about individuals working harder. I'm talking about the system being better connected to enable more activity. But I would reflect that we often spend too much of our time as a system thinking about the context within which we work. The context is the reality within which we work. There's an awful lot we can influence, and there's an awful lot that we control. We are responsible for stewarding £1.3 billion worth of spend, and it is up for us to determine how that is best deployed. We have 13,500 people within our charge, and it's up to us to think alongside those colleagues how best to provide our services. So we do have an awful lot within our control, and I want us as a board to really grab what we can within our control, think about what we can influence, rather than spend too much time reflecting on the challenging context that we work within. Sarah, in terms of the unsustainability of our services, absolutely. And what we're dealing with here, I want us to make sure we keep in mind that the financial plan, financial challenges we have as an organisation are just a consequence of the service sustainability challenges, the clinical sustainability challenges, the challenging outcomes that we're delivering across our service. So it is just a financial consequence of those with a pound sign on it. And therefore, it's some of the underlying things we can do. We have often tried to cure the symptom when it comes to finance and not the cause of the issue. And I hope this allows us to reframe that challenge into a proper whole system approach. And Winston, I just want to reflect on that productivity challenge that you've effectively alluded to, and that Health Foundation report that I mentioned. I think it does give some clarity over the system productivity challenges we've got as an NHS across the UK, and how we need to reflect on the digital investment that needs to be made. And I recognise my conflict of interest in saying that. The OD support that we need as an organisation to make sure that people can act at the top of their licence, and the prevention actions that we need to take alongside continuity of care, which I know is something that we very much rely on general practice to maintain. So there's a lot within the strategy we need to develop in order to respond to this challenge.
Very helpful. And I think we teed this up for the conversation about the strategy and how we move forward. I think it's all been very helpful. I think this has been a useful conversation, and I think what we are issuing as a board is a license to be courageous inside this space, to be innovative, to think beyond and to think differently and to think radically about what those services might look like in the future, and to think into the future of those services instead of just the stuff we need to address every day. I think that's been well put, Hugh. It's not, our financial position is just a consequence of an unsustainable system, and we spend so much time on the financial question, and we worry enormously about it. But the reality is, it's the system that's driving that financial position, and we have to grip that. It's our responsibility as a board to do that. We are evading our responsibilities and our commitment to patients and well-being of people who use our services if we don't address this. However painful or challenging or uncomfortable or unpopular that journey is going to be, we have to go down that journey. Thank you very much. Let's take a refreshment break and return in 10 minutes. Thank you, colleagues, for coming back so promptly. We are running a little bit behind our agenda, so I'm keen for us to progress as quickly as possible. I'd like to welcome Dr. Warren Lloyd and Becky Temple-Purcell, who've joined the meetings. Your item is some way on yet, but you are very welcome to observe the meeting as it's currently undertaken. We will try and get to your item as quickly as possible later on in the agenda. Okay, can I move us to, on the last item before we broke, just to say, record, Claire, that we noted the work in progress that's been made in relation to the financial roadmap, and we look forward to further conversations as we start to see some iterations in the future. That would be great. Okay, so if I could take us to our next item, Hugh, Integrated Performance Assurance Report.
Diolch, Cadeirydd, and I'll make sure that I don't repeat conversations. I appreciate some of these reports merge into each other and it does feel a bit repetitive, so I'll make sure that I only do this by exception. A few areas that I don't think we've discussed that I'd just like to highlight. The first, within urgent emergency care, recognising that within ED there have been a significant number of people, 44 patients waiting on average over 12 hours in October. We have seen very positively a significant reduction in ambulance delays. Those waiting over 4 hours has reduced to 109, which is the lowest since before COVID, and that's certainly worth noting and reflecting upon. Therapy waits. There has been an improvement in the 14-week wait position for the second month, but we are still the worst in Wales, and that is something that's a sobering position for us to find ourselves in. We've talked about pathways of care, we've talked about ophthalmology, we've talked about cancer, so I wasn't going to particularly raise those in any sense. Just to end with a positive on our diagnostic position as well, our breach reduction has been a very significant reduction and improvement from around 8,000 in January to under 2,000 in October, and that's the lowest level now since early on in the pandemic, so some very notable improvements there. I just wanted to jump into some of the escalation challenges. We've already started to discuss this. Sarah raised a question around escalation earlier. Clearly, community integrated medicine is the most challenged clinical care group, but we have with a number of areas in escalation. The position in mental health on quality and safety has been escalated from level 2 to level 3. And then in allied health and health sciences, the strategy, planning and fragility domain has been escalated as well to level 3. We have now included public health measures in the or population health measures, I should say, within our escalation framework. There are 2 measures that we're including at this stage. It's not a comprehensive assessment, but what it has highlighted is that there is a lack of business continuity, or overdue business continuity case reviews, particularly within mental health, allied health and health sciences and primary care. Those are areas of concern in that space that we need to make sure that there is a focus on addressing the business continuity plans that need to be reviewed. I guess, Chair, this does reflect some questions that we may want to consider today, or I'm conscious we've got a escalation conversation which we'll have in board seminar, and maybe questions that we will keep until that discussion. The first for me is on trajectories on performance, where I think there's more work we need to do to embed a different approach across the organisation in being more scientific and recognising the interplay between demand, capacity and backlog. And we've seen that playing out in the challenges we've got in cancer, where reducing our backlog necessarily, mathematically, reduces our performance when that backlog is reduced. But of course we could have trajectorised that somewhat better at the start of the year. The second point, which is around the escalation process, is the pace and responsiveness of the action plans, but that also I think belies a significant piece of work we need to reflect on in terms of the underlying enabling conditions we've got across the organisation to enable sustained and successful improvement. And I think that's a conversation, again, we can elaborate on in our board seminar. And we will come back to the strategic focus on urgent and emergency care later on the agenda. I think what this emphasises to me is that assurance isn't just about tracking the indicators, but understanding the story underneath and the choices we need to make as a response to those metrics. So, Chair, with that, happy to open to discussion.
Thank you, Hugh. It's noted that actually we've discussed a number of these items beforehand, and we will discuss them at the next board seminar on the, I think it's the 11th of December. Rodri.
Yeah, thank you, Chair. Regarding the patient spending time, we'll touch on that in the UEC paper. But just regarding workforce, I'd like to just have one kind of explanation. It says, obviously, it is an increasing trend in the short term and the long term. This kind of, is there any reason for that in particular? Is it just kind of sickness, or is it work pressure? Because there's a lot of things that could contribute to that. Just to have some kind of an idea.
I mean, I haven't got the exact detail of the reasons for sickness absence, but the rate that we are seeing this year is exactly the same as the rate last year. And we have recently reminded our staff not to come into work if they're in a clinical area, if they show the signs of cough, colds and flu. So we are seeing flu circulating within our communities, and therefore we would expect something similar with our workforce. Just to add to how we are supporting sickness absence, following previous reports here around when workforce support our clinical teams with the management of absence, we have now created a post within workforce and OD for each of our service areas to help them with absence management.
Thank you, Lisa.
Thank you, Lisa. Colleagues, Andrew, did you want to say something?
I thought it was just, I know we've covered a lot of areas, but I thought there were just a couple of things I should cover because they're areas of ministerial priority and performance areas I think we should probably just mention, even for the record. I know we'll go into some of the detailed piece around urgent emergency care later, but I think we should recognise from a performance perspective the improvement in ambulance handover delays and the fact that we're not only that we're below our not only below our annual plan trajectory that we submitted at the start of the year, but we're also now tracking below, about 20% below what our targeted intervention de-escalation criteria level was. So I think just in terms of some of the things that we've been monitored on as an organisation, it's important we recognise that. I think we will hear later on around how delivering that has, we used to talk about the hidden or the invisible risk that was in the community from patients waiting for ambulances for unhelpful lengths of time and unsafe lengths of time. I think what we will hear later on, and it's reflected in the 12-hour performance numbers, is the impact the fact that that's making some of that still very much more visible within our acute sites and how that's feeling in terms of a risk to manage. That said, our overall percentage of 12-hour delays is lower than it was 12 months ago by about 4. We were at 12% last year. We're at 8.5 now. The target's 7. So we've made some progress on that, but it's still a big issue, and it's still, for me, a really big indicator of quality and experience, and we'll go into that much later. The other area I just wanted to touch on was planned care and referral to treatment times, because they're another big area that we're monitored on. And just to give an update that we still remain on track to deliver 52 weeks at the end of the year. There's risk we're managing due to sickness and issues like that, as you would always expect operationally, but we're confident we'll deliver that. And the obviously the funding we've had from Welsh Government around outsourcing and insourcing additional outpatient capacity to further reduce that is playing through, and will increasingly play through as we go through the next 4 months. On 104 weeks, we should end December, so Q3, with a further improvement with just 17 patients over 104 weeks. Still not really where we wanted to be. I wanted to be at 0, but there are well-rehearsed issues there in terms of theatre staffing challenges in Glangwili and just some specific more complex cases around ENT and ophthalmology that are particularly proving challenging just because of that capacity issue. But we're making good progress, and we are confident we'll deliver 0 on 104 weeks as well. And on 8 weeks diagnostics, we're making really good progress as well. The one area of risk remains ultrasound for us, non-obstetric ultrasound. In terms of the target performance, we've got a risk of around 500 patients to the end of the year. Part of that isn't around resourcing. We've had money from Welsh Government, but the provider that we had contracted with now declared that they can't deliver the level of activity we need, so we are seeking other options to make that gap up. The gap a couple of months ago was around 800 patients, so we have mitigated that further, but that's still a remaining risk around delivering the 8-week target for the end of March, but something we're actively trying to progress. So I just thought it was important, given the ministerial focus on some of those and our TI focus on some of those that I just mentioned, where we're at.
I think it's more than a ministerial focus. But you are absolutely right, and that's very reassuring. And I've given the Cabinet Secretary the reassurance as well that we will hit our targets at the end of the financial year. So it's good to see progress and sustaining that progress in this space. Eleanor.
Thank you, Chair. I was looking at the trends for our most concerning functions in this paper, and I pick out two of them to ask questions on. One is around community and integrated medicine. The quality and safety has been read every month since April, and I'd just like to understand that a little better, and more to the point, be assured that we are focused on doing something about that. And the second one for that was around the allied health professionals, and it's there around strategic planning and services in that space, and what are the risks there, and what do we need to understand about that as a board? I know it draws us into a little detail, but I'm much more interested to know that strategically we are making sure that these are going to get out of these places.
Thank you, Eleanor. You?
Yeah, thank you. If I can ask colleagues if I can navigate that then. So in terms of our approach to domain escalation, that would be the responsibility of each domain lead. So for community and integrated medicine, for safety, that would be Sharon. So if I can ask Sharon to come in on that, and then maybe Lee to come in on allied health professionals. Thank you.
Lovely, diolch. Thank you, Eleanor. Yeah, you may recall that the metrics that we've got within this domain for escalation is based around the foundational governance arrangements, which relate to incidents that are open over certain complaints, national reporting. And community integrated medicine care group is the biggest care group in terms of inpatient activity. So the majority of our inpatient beds, with the exception of some planned and specialist care, it sits within this care group. And therefore, the majority of incidents that are captured are related to our hospital settings. Although we do have some in the community and primary care, but the vast majority are in that space. So they have the vast plethora of data. We have set assurance scores, which then allow us to de-escalate, and the majority of the CCGs have de-escalated from that level 3. The Community Integrated Medicine Care Group are making significant progress in this space, and we had a presentation to IQFPD yesterday, and we've got one coming to QSEC next week. So we are seeing improvement trajectories, potentially not at the pace that we would have wanted to have seen them, but Mark and myself are meeting with the care groups that are in that level 3 so that we can really scrutinise and go into detail into what the challenges are that they're facing to make sure that there's enough executive support in that space to help them to improve. Yeah.
I'm glad that we'll be seeing it at Quality and Safety next week, so any assurance to the next board can come from that.
Very good. Okay. Thank you. I'm not proposing we... Lee, if you respond to the item, and then I'm going to close the item.
Sorry, yeah, that was in relation to level 3 for allied health. Is that right? Yeah.
Yes.
So what we've seen is progress in trying to respond to the radiology challenges, which was what led to the original reduction from a 3 to a 2. But what we've seen this month is I guess we've got a wide set of challenges, particularly around radiology we mentioned, but pathology we know about. And then the other one is ultrasound, which has become a particular issue now. So I guess what we're seeing behind these numbers is a lot of dynamic change happening, and we address issues as best we can, but obviously sometimes then more issues present themselves, so we're trying to respond to each of those as we go. And I guess in terms of fragility, it describes the extent of which we've got those pressures across the system. So the teams are working very hard on those risks, and they're not risks that we're not unsighted on. But clearly there are some pressures within that care group.
Great. Okay, I'm going to close the item and ask that we offer assurance or seek, or we are assured in terms of the operational delivery and the mitigating issues around improving performance. Semi-assured. Great. Okay. Can I move us on to our next item, which is the board assurance framework?
Yeah, I'm happy to take that, Chair.
Yes, please.
So it would be so it'll be quite brief, because obviously this is discussed in a number of areas as well, but it does give the board the overview since we last presented this to board. And all the planning objectives are mapped to the committees, so that the committees will have seen where we are with those. And I guess just to call out from the paper, the key areas are that we are on track for all of our 4 strategic objectives in terms of where we are with the timelines that the board agreed that those have been set. So I get it's just for questions, Chair, because the dashboard is interactive for members to go in there and look at it, but just the overview is that all planning objectives are on track, Chair.
Right, okay. Thank you, Joe. Colleagues, any questions or comments? No? Okay, let's note, but we will note the revised date will be May 26th, not March 26th, due to the amount of work that needs to go into realigning it.
Yeah, once we've done the strategic refresh work that we're working through with Lee and Lee's team, it's just going to take a bit longer because we'll need to redo all the principal risks and all the metrics to be able to give the board that overview so you can see where we are. So that we've agreed that we'll do that for the May board, Chair.
Great, okay, thank you very much. Let's move to our next item, refreshing the Healthier Mid and West Wales strategy. Yes, please, Lee.
Thank you, Chair. First of a run of papers from myself. So I'll be relatively brief, so just highlight a few key points that are in the paper. So firstly, we've been working very hard on the engagement to support the strategy refresh. That's continued over the last couple of months since the previous board. There's been a busy programme of activities to engage across staff, partner organisations, members of the public and specific groups as we've identified in the paper. I'd particularly like to thank Alwena and her team, as well as members of my team, for the amount of time and energy they've dedicated to this and gathering this essential feedback. Particularly as much of that has often been outside of normal working hours, so people are giving up quite a lot of their own time to support it, for which we're very grateful. Secondly, in the paper, we are progressing at pace the development of the Primary Community Strategic Plan. My thanks also to Jill for her leadership on that and for the team that have contributed to the progress on that to date. We are aiming to bring that to board in January, and from there our thinking is that we'd look to develop individual strategic cluster plans as a way of progressing the implementation and the delivery of that strategic direction. You'll note in the paper we are seeking support in principle from board for pursuing some external expertise to support us with that phase of it. I'll welcome board's views on that. Obviously what we're keen to do is really turbocharge this as much as we're able to and give that impetus to the clusters so they can really drive forward the health board strategy through that mechanism. The third point to highlight is the update on the discussions we've been having with Welsh Government on our strategic capital plans. That was obviously referenced earlier. We have been making some good progress in that regard and seeking to agree a way forward. As is noted in the paper, Welsh Government have now requested in the most recent meeting that we produce an addendum to our programme business case, which recall we produced and agreed in 2022, and we've been asked to do that for early in the new year. That is, of course, a very positive development, and we're very enthusiastic about that. But it is a considerable amount of work to undertake over a short period of time, alongside everything else that obviously we're describing in this paper and in the previous papers. So there is a lot to do in a short amount of time to complete that, but we are working through it at pace. And then finally, I just wanted to reflect the significant discussion we had at the October board seminar on the transport challenges across Mid and West Wales. We know how important that is to members of the public, and the reality of those difficulties for members of the public, and what we're looking at is what we as a board can do to respond to those very significant and understandable concerns that our public have about the availability and the cost of transport options, given of course we've got such a large and rural geography. So I just wanted to pick that point out as well, because it is foremost in our minds with not just strategic changes, but also the situation today in the delivery of services. So thank you, Chair.
Thank you, Lee. Colleagues, questions? Sarah? Michael? Let's take questions from there. Yep.
Thank you, Chair. Thank you, Lee. It's a question really picking up on the point about bringing in external consultancy support for the cluster leads. Is that being driven by our capacity or our capability? What's that added value that would bring? Because I'm very mindful of spending funds on external consultants, can be quite a contentious issue. So I'd like to understand the value. And at the risk of banging the drum I always bang on about, which is, what is this saying about our transformational change capability? Is it going to be sufficient? We're talking about the seismic shift and the radical shift that we need. I'm worried that we don't have that capacity or that skill base within the organisation. And is this use of consultants a symptom of that, or is it unrelated? So some clarity around that would be really helpful. Thank you.
Thank you, Sarah. Michael?
Actually, well, Sarah's nicked one of my two questions there.
Sorry.
On that, because on that consultancy thing, I was fortunate enough to be able to attend on behalf of the board and a number of colleagues the NHS Wales conference at the beginning of this month. And at that conference, there was a presentation on clusters and the kind of community impact of them by a cluster lead from South Pembrokeshire, which was, now we're talking about turbocharged, that was turbocharged. It was very impressive. And so my concern, well, my query is do we need external consultants? Because the turbocharging, the turbo engine is already in the organisation to an extent. External consultants might be able to put it into a kind of a context, but we've got the materials there. We've certainly got personnel there. And my concern is also, Sarah mentions cost, but also delay, because, you know, by the time you do procurement and this, that, and the other, it's like, you know, 6 months down the line. So we've got the people, certainly from my experience, we've got people in the organisation who can give us a real turbocharge anyway. So that was part of it. That rolls into Sarah's question. My other thing was, as usual, I bang on about transport, and I see that we're talking about having a kind of a wider plan, as I understand it. I think that is absolutely fundamental. So I want to query about a timeline for that. I welcome that that's now reaching a profile. Again, I think we need to get on with that really quickly. And again, something, so it's got to be a high priority in my personal view. Yeah.
Thank you, both of you. Good questions. Well, really relevant to what we're discussing. Lee, do you want to come back on those?
Yeah, very happy to. Thank you. So I suppose the first thing to say in terms of primary community and transformational change. So, so in answer to Sarah's question, I guess obviously it is an element of both. So I think what we've recognised, and we recognised actually in the last meeting, the board meeting on the primary community strategic plan, obviously we made comment on I think it was your question, Sarah, about the pace of that. And we referenced the fact that actually the people we're asking to progress that are the same people who are having to run the day-to-day delivery of the primary care services and so on. So there is a capacity element there. And I think it's less capability, but I guess what this does give us the opportunity is to draw on expertise and experience from across the UK, from experts in the field. So that allows us the opportunity to test our thinking against that. And obviously there's a lot happening at the moment across NHS England in particular, around neighbourhoods and so on. So it would be, we wouldn't want to pursue a path that doesn't draw on that learning, I think. So I think that's the sort of thought process behind it, recognising, of course, that there is always a cost component to this, and we've got to assure ourselves that that is providing us with value. And I guess on Michael's point, so I completely agree. Actually, we've had a number of cluster lead meetings over the recent months, and I think we've got the leadership clinically within our cluster leads to really help us chart the course that we want to chart. And I suppose what we're really trying to do is embrace all of that and give them the additional expertise and input, I suppose, to lift that up to another level, and then think about how we change our organisation to make the most of those skills and ideas. Because I guess, just to go back to what we'd said previously, if we continue to do broadly what we've done up to this point, then we're going to get the same sort of results. So although we've got those great people, we need to find a way of really catalysing that. And then the final point, I guess Michael's point on transport. So yeah, transport has always been a significant concern for us as a health board. You'll note reference in the paper to the fact that we've had transport work going on for some time, linked to our strategy and so on. I think I thought we had a very useful discussion in board seminar. So what I've asked the transport team to do is consider what that process might look like, bring that back to another board seminar so that we can then consider what the options are for us as a health board, because there's a lot going on that I can't do justice to now in sort of a brief summary, but there is more that we can do also, and there's some considerations for us. So I've asked them to bring that together. So we'll certainly reference that in January board again, but probably in a board seminar early in the new year, we'd want to consider the outputs of that work.
Great. There's a number of people who want to come in, and then I'm going to close the item. So Rodri, then Jill, Phil, and then Mark. Rodri.
Yeah, thank you. And Sarah, Michael, you've touched on that point. Obviously, it's coming to here now because it's going to be over 25,000. That's why you need that approval. Yeah, I just want that assurance from an audit point of view that it's not going to be a direct award. You said the specialists out there. It needs to be an open procurement process. Yeah. And also, I just wanted to, well, I don't know, that's the main question. If you could give me that assurance first before we move on to the other question.
So we're seeking procurement advice on the best way to proceed with it, Rodri, and obviously we'll follow with all the guidelines on it, because we haven't finalised exactly the specification yet and the scope of that work. We're not at a point of agreeing exactly what the procurement process is, but we'll certainly operate within the in the guidance of procurement advisors. We're not going to circumvent that at all, and we will bring that back through FPC as well in due course as well. So I can give assurances that we're not going to do anything other than follow the appropriate routes.
And I appreciate with procurement, kind of we'll see what happens, but do we put a kind of a cap as in what would be the maximum spend? We put a cap as in, well, because it's over 25,000, but obviously we go through the process first, is it? Because really, as a board, if we give approval, I just want to also have that assurance that we're not going to be spending a vast amount of money or kind of more than perhaps, it's an awkward one, isn't it? But I think we need to have that due diligence as well.
Yeah, agreed. I'm going to bring Hugh in to answer this.
Yeah, sorry, it's quite a simple response. We've got a defined process, and we'll follow that process, and we know how to manage this, and it needs to come through the procurement report then that will come to board.
Be assured, Rodri.
Okay,
Great, okay. Second question?
No,
That was
it's
it?
fine.
Great, okay. Can I then go to Joe?
Yes, thank you. And it's for others, I know we'll sort out the process, but just to be helpful really in terms of where we are with our clusters. And you're absolutely right, Michael, we have some really impressive leadership. We've got a number of significant programmes that are having an impact, a positive impact on the care of many, many thousands of individuals actually across our communities. What we're being asked to do though now is to move to that next step that will allow that seismic shift that we've been talking about. And that may be, for example, looking at our clusters, having devolved budgets that are for the services for their population in a much broader sense, becoming possibly commissioners of planned care and thinking about how we change that model of delivery for the future. We need some external expertise where some of this is happening elsewhere in the UK to help us think about what we would need to do to translate some of those programmes on paper into something that may be an operational delivery model that will support our whole system in a very different way. So I think it's stretching our thinking, and that's the value that we would want to see out of that external support and advice to help us think about that model going forward. Thank you.
Thank you. Thank you, Joe. Mark, I'm going to come to you.
Thanks, Chair, very much. And thanks, Michael, for bringing up that discussion that happened at the NHS Confederation. It was probably the most inspiring talk that happened that day, and that was delivered by one of our primary care cluster leads who engaged the room and engaged everybody in a really important discussion. But that individual is a cluster lead, is a GP partner. She told us she's carried out 38 pilot projects and how she's done all this amazing work, but they're pilot projects. So she and our clusters need support in how we spread and scale that work. And I think what that presentation and what you're going to hear today from the rest of clinicians is what really engaged, committed clinicians we have in this health board. What we need to do is work out how we support them to introduce those ideas and develop these pilot projects and make sure that we're actually delivering on what they want to do. So I think if that involves consultancy, then that's what we need to do. But I think Sarah's right. How do we support all of our clinicians to get these projects? Because there's a lot of enthusiasm out there.
Yeah, I think you're right, and I think it's inspiring to see this work because often clinicians are doing this as well. I think Sarah's point is well made, which is how do we sustainably create a resource within this organisation that delivers what those kind of innovations need, at critical times. And it does feel like going outside a bit is, on the one hand, I agree with you, Lee, if we can pull in more knowledge and expertise, that's immensely useful for us. On the other hand, we need to be careful of using externals because what usually happens is we use them, they go away, and nobody's developed the skills or made it sustainable inside the organisation.
Can I just come back one quick point? So I'm afraid I didn't answer that question, did I, about the internal capacity? So I guess just, I suppose, to reflect then in the context of this conversation that we do have an element of transformational and change capacity in the organisation, clearly, and that's supporting us deliver a very considerable change programme, if you look at things like CSP and others. But the scale of our ambition in the organisation is such that it does require us to really think about that change capacity. And I would say particularly within the context of primary community services. So mostly that change capacity is pointed towards more of the hospital type services, I would say. And so I guess to sort of Mark's point, part of what we need to consider with this is there's a short-term point that we just talked about now, but actually there's a sustainability question around what do we wrap around our clusters, our clinical leadership within primary community care to really shift the balance in the way that we've talked about within the strategy and has been raised today.
Very helpful. I'm going to come to Phil and then I'll close the item.
So, I mean, this is a really important item, given everything we've discussed today, given Sarah's question earlier about how we set the right strategic direction going forwards, and being really having a critical look at our strategy back in 2018 and see what have we learnt from that, what have we seen over the last 7 years that's different that we need to draw on, because I do think there are things that we need to emphasise more deeply. I do think we also need a bit of a mindset shift, which I think I'm feeling around the board. One of which is this idea of out of hospital care, which, I mean, the NHS does have a thing about saying out of what things are not. But I suppose in a way, out of community, in the way everything should be really within the community and by exception outside community. And we don't have that mindset at the moment. We're quite a long way from that, and we need that in this strategy. I also think when you speak to those GP leaders who I agree, we've got a really good foundation with great GP leaders who want to come forward and support. Their point to me has been, please don't look at us as the problem, look at us as the solution. We can help you solve this, which is a great place for a board to be in. And I think, you know, there's a risk as a board we end up in a scarcity mindset. I mean, I would say we should be much more in an abundance mindset here. I know the finances are challenging, but when you look at the kind of communities that we have and the community teams we have and the GP support we've got, also the way our clinicians connect with each other in our health board, I do think we've got we have an abundance, I would suggest. Brief point on the consultancy. I understand the concerns about it. I think because of our geographic location, we do need to look outwards. We do need to draw on others' experience, and we need to therefore be really careful in the way we engage with others to make sure they are bringing in those external voices that help us go faster and expand our thinking. I think also in terms of our capacity around transformation, I think there will be sometimes times when we'll need to draw on some experience for a brief period of time that we won't want to necessarily engage in an employment relationship, and this might be one of them, accepting the point that we do need to build our own basic transformational capacity. But yeah, that's all I had to say, Chair.
Okay, thank you very much. In the interest of time, I'm going to move us on. So I think we're duly noting the progress, Lee, around the refresh and endorse the approach, subject to, in principle, we endorse the approach to the procurement of the service, obviously ensuring that it complies with the procurement rules as part of that process. And we note the work underway towards the completion of the addendum to the programme business case. And that, I agree with you. I think that's an enormous amount of work, but also it's very exciting for us to be in that territory as well. So thank the team for all their tremendous contribution to this. Thank you. Let's move to our next item, which is an update on the community schemes. Lee, we're back to you.
Thank you. Thank you very much. So board members, as we've already discussed, will obviously be very aware that a key emphasis of our strategic direction is the shift towards a community model, and integral to that is the development of a range of community facilities across our 3 counties. We regularly receive reports on progress with these schemes at our Strategy and Planning Committee and through our Capital Subcommittee, and we have brought updates to Public Board on a number of individual developments at the relevant times. There is an opportunity here to see the full suite and how all that has progressed. I should emphasise that what we've got in the paper are the more significant developments, the larger capital schemes. There are, of course, a range of other smaller schemes which we could have included, such as the recently opened Sexual Assault Referral Centre in Aberystwyth, but we kept it to the major projects. As you can see, we've got a pipeline of projects, some of which have been completed. Those who've been to Cardigan and Aberaeron will know how impressive those facilities are and how transformational they are. And we are bringing, and they are bringing significant benefits to our communities. Then we have others which are due to open over the next 12 months, so Pentre Arwel and Carmarthen Hub in particular, and others that are in the planning phase, so specifically Cross Hands, Fishguard and Kilcarran, which obviously we've had updates on through board previously. you'll note that we have ambitions to go further than this, and there's quite a significant pipeline there. And you can see the areas where we'd like to make progress, which of course is subject to the availability of funding. I wasn't going to say anything more than that, Chair. Happy to take any comments. Thank you.
Yes, please. So let's take Maynard and then Rodri, and then Eleanor. Winston after that. Okay.
Thank you, Chair. Comment first of all about cross hands. Just looking at the report, it's again showing that we are limited in our scope of what we can change by the availability of capital. Goes back to an earlier comment on that. Couple of questions really, Lee, about the process. We've got a lot of schemes here, and we've already talked about capacity for change. How long does it take typically from the development of a business case to actually opening the doors on some of these developments? Because again, it's partly the capacity to develop the business cases, but also the availability of capital influence that. And as part of that question, are there any discussions ongoing with Welsh Government who set out the process we have to go through about changing the process to improve the process in that area? And finally, a specific question on Kilcarran. Any idea when the housing consultant will be able to report on that? Kilcarran has obviously been partly implemented in the work that we'd already authorised with moving into the community from Tregaron Hospital. But I'm just concerned that that's a scheme that just seems to be going on and on and on without any clear end point.
Thank you, Maynard. Rodri.
I just wanted to just comment. I have to say it's a good paper, and you know what, congratulations to everybody, because there's so much work that's been done on the completed projects. Obviously, there's some there that haven't been completed yet, but we're talking projects that are millions and millions of pounds worth. So it's I have to congratulate and perhaps pass that congratulations back to all in the team. And back to Maynard's point here, Kilcarran, it's been 20 years. When's it going to start? Thanks.
Great, okay. I'm going to come to Winston, then I'll come to Eleanor.
Yeah, it's a quick comment, really. I think it's a really good paper put together. It kind of makes that transition from what we've done before to where we're going in the future. So I quite like the images that we'd put in there. I've visited Tregaron and I've visited Cardigan as well, and the impact on the staff and the patients there is quite striking. There's a huge difference between the atmosphere you get walking into those areas than you get walking into some of the other hospitals as well. So I would encourage us to move with rapidity as much as possible. Question, a couple of things. It seems to me that those schemes that are managed by other people are slower, and maybe we just learn from that by making sure that's more within our controls. Third thing, we've got a number of, if we look at the balance between each of our counties, there's an awful lot to be done in Pembrokeshire, actually. And I'm just thinking, how do we release a resource in order to make that happen? So we need to maybe think a bit more radical about that. Can we sell something? Should we think about the footprint we've got in other places? Because it seems to me, if we don't think in those lines, then if we open new facilities, we're going to, by definition, have more staff to staff those facilities, which we can't afford. So we got to think more radically about our existing estates. And finally, I think I really support this paper as well, because I think it starts to set direction in terms of where we think our services should look like in the future. If we think about it, moving away from hospitals to community and having a number of centres, I think that's the way to go. So, thank you, Chair.
Thank you, Winston. Eleanor.
Thank you, Lee, for the paper, and my thanks to Hywel Dda and the team as well for all the work they've done on it. They work really hard to deliver these. First point I want to make is to reinforce Maynard's point. We've said at board many times we don't want to see the diminution of the cross-hand scheme, and every paper I read there is a suggestion that it is going to be less than we wanted it to be in the first place. I won't make any more comment on that. Second point is, this is a really lovely paper following the discussion we've just had around the refresh of the strategy, the Mid Wales strategy. These are the living embodiments of where we want to get to. Care in really good places, near where people live, where we can put primary care, we can work with clusters, and the point that Jill made is absolutely right. Clusters and the health board, we're all caring for the population in the Hywel Dda area, and working more closely together would be great. And if we can do it in these settings, that works really well. I also think it fits with the public health agenda and the preventative agenda. We're actually investing in places which look like we really care about what we're doing as well, not just a hat at the back of wherever it is to get people going in and out of. It's really important. I think the geography of them is great. The pipeline, yes, it's aspirational. I'm sure we'll work to it. But I think we should really focus on getting the best into these centres. Every one of the ones I've been to is well liked by the staff that work there, more importantly by the members of the public that I see in there and the services they can get near home. So commend this. Let's not lose Cross Hands in its fullness. And I think they are an ideal model going forward.
Great. Before you respond, just my observation would be, I share everybody's view on this. I think it's great work, and these are flagships and exemplars of what we can achieve in these areas if we want to. If I have a concern, I'd like to understand the full strategic impact of some of these changes, because I think that underwrites the business rationale behind why we're doing this. So, and that feels really important to me as we constantly struggle with this shift towards more primary care, community-based services. How do we understand the full impact of this? And specifically, the list of where we could develop these kinds of potential opportunities compared to where we have is significantly longer. I suppose I feel frustrated partly because we're not progressing this as quickly as we would have wanted to. But it's fantastic work that we've done so far. My last point is, I'm just wondering around what the total cost of the work that's been undertaken on developing the Cross Hands initiative is going to be, because we're asking here for permission to ask Welsh Government to underwrite another £3 million cost for this. It's got the kind of, I'm kind of partly thinking about the 100 million bat shed that was that had to be paid for when they decided on the HR2 rail service. I'm just wondering about how much money would we have put into this stage of even getting as far as, well, we're not even as far as a business case. How much money would it have cost us so far?
Okay, I'll respond to as many of those points. Just to thank everyone for their comments, because I think this is very much aligned with our strategic direction, and as you say, it's an embodiment of what we want to achieve, and I'd wholly endorse the thanks to my team, Eldeg and others, for the work that they've done and the resilience, I suppose, they've shown in trying to take these projects forward. So I'll just respond to as many points as I can, as quickly as I can. So Cross Hands, firstly, what we've seen with that as context is we did get to the point of outline business case, and we were midway through the full business case, so we were right at the latter stages of that. And of course, what we've seen is that coincided with a significant inflationary increase in construction costs, which took it to a level that was beyond the envelope that Welsh Government had previously allocated for it. So we had to significantly revise our ambitions then as a result of that. What we're very conscious of is that the community of Cross Hands and surrounding areas is waiting for this, and have been waiting for a decade or so, I think, long before my time. So we're trying to progress it to the point as quickly as we can. What we've got here is, I suppose, to some extent, I've tried to push that a little further and say, well, actually, if we were to consider this in a wider sense, particularly around addressing some of the service challenges we've got and the state challenges we've got in, say, Glangwili, and incorporate that into the cross-hand scheme, could that give us something a bit bigger and a bit better, and not lose the amount that we were planning to lose? So I suppose I've tried to push that, if you like, which has led to the subposition. That said, because we had to significantly redesign the scheme, the fees were always going to be the fees, so that hasn't changed the fees. And to answer your question directly, Chair, we'll have committed something similar to what's in the paper now already, and that's part of the reason why that scheme, on a value for money basis, is quite a hard one to kind of argue for at this point, because it's weighed down by quite a lot of work and fees that have already been committed. To Maynard's point around the business case process, so clearly that depends on the scale of the project, to give an obvious point. Some of these we're talking, so Cross Hands is in excess of £40 million now, so it does take a number of years to go through that process and a number of stages of the business case process. What we've often seen, though, with these is it's not so much a linear route to an outcome that causes the delay. It's the fact that we have to go back at multiple times because something happens or something changes over the duration that allows us to. That means we have to go back a couple of stages, which is what's happened with Cross Hands. I don't think there's any aspiration within Welsh Government to look to significantly change that process. It follows a very clear set of guidelines, which obviously is intended to ensure that we can demonstrate value for public money, which I think is obviously a legitimate aspiration. Nonetheless, it does require quite a number of pieces of work and a lengthy time to commit to it. On Winston's point about schemes managed by other people, so I guess I'm not sure I would say that that's the case. I think it'd be a bit. I couldn't say that we would be quicker at delivering anything. I think what we've seen, though, in things like Carmarthen Hub, the complexity associated with retrofitting a health facilities into an existing building is very, very difficult and comes at quite considerable cost, and that's part of what we've seen within that. On the other side of that, though, I guess to pick up Eleanor's point, we know that these sort of developments provide much more benefit to our communities than just health facilities. These, predominantly, these are in town centres. They provide economic benefit to the wider communities that we have, and therefore they shouldn't just be seen in the context of extra clinic capacity and so on. They're part of providing a beating heart within the communities, and then. I suppose the other thing I would just like to add is, in terms of the strategic impact, strategic direction, I think within some of the proposals we've got here, there's opportunity to consider a wider benefit for communities, obviously working with county councils around care campuses and so on, associated with some of these developments, could really give much more of an integrated benefit to our communities. So we'll certainly be looking to pursue those as much as we can as we work through the relevant schemes. And on the Kilcarron question, so from a health perspective, we know what we want to do. We're ready. That's been the case for some time. On the report that was mentioned, my understanding is I think that's with Ceredigion County Council now, so it's being considered within the council, and obviously we'll feed into that process. From our perspective, we want to progress with it as quickly as we can, obviously, but clearly there's a lot to consider within the council.
Thank you, Lee. Very helpful. Did you want to say?
It was only just. I was also reflecting on your point about what the full strategic impact is, and Lee's kind of covered the wider economic benefit and also the potential for broadening some of these schemes with working with partners and sort of health campuses. I do think that's something we would want to explore. I also think we're creating facilities that are as flexible as possible, so that we can adapt the kind of things that we do in there, or we do with communities and partners. So to take advantage of new AI, tech, digital, new diagnostic opportunities. I think the kind of space that we're creating would allow us to do that. The other thing about the full strategic impact is we'd need to consider what will be the full strategic impact of having a very community-minded workforce in a way that we perhaps haven't quite got right now. You know, specialists who are population health doctors, not just you know, sort of their ology. And I don't know, we've got the mental health clinicians sitting there. I mean, we could learn probably quite a lot from the way mental health have done that over many years. It is incredibly frustrating, the progress, but we all feel that, and we're all working really hard together with a lead to try and make that progress faster, because it is the thing that will build confidence in our communities, in our staff and our public, that we're doing the right thing in focusing so much on communities.
Very good. Great. Okay, thank you for that. So let's take assurance from the paper and the progress being made in relation to the delivery of the community schemes. And then let's also approve the submission of a request for resource from Welsh Government to scope the full business case. Great, thank you, Lee. Can I move us on to item 16, which is property leases? Now, I'm going to presume that we've read this. This has already been scrutinised. So this is really for us to approve the progression of legal arrangements. So, Lee, if you want to introduce the item.
Chair, just to save time, I'll assume it's read, and if anyone's got any questions, I'm happy to respond to them.
Great, okay. Eleanor.
Question, the moving of staff.
Okay, let's keep this brief, colleagues, because we're running well behind in terms of our agenda.
The integrated working at Eastgate goes really well. We had a meeting of the vice chairs there recently showing how well the local authority, the third sector, the not-for-profit company and the carers work. Is this taking out the staff will that have an impact on that good integrated working that we have?
That was the question I asked as well. So I've had assurances that the teams will be able to continue to work in the way that they want, in an integrated way, and we're retaining some capacity in Eastgate to facilitate that. So this has come from the teams themselves, so it's not being imposed. So I don't think that's a risk, Eleanor. Thank you.
Okay, I'll hang on to it. I'm not quite persuaded, because I've seen the way several times how they work in an integrated way inside the building.
They do, yeah.
Okay, thank you for raising that point, Eleanor. Maynard.
Just a couple of very specific points, so hopefully very brief. Cresize service charge. It says it's going to be a fair charge. Are there actually any contractual limits on what a fair charge is? And on Rydal, it says the council has opted not to apply that. Have we taken advice on that? That is an appropriate thing, so we're not saving up that charges for later on.
Good point. Yep.
Okay, I'm probably going to need to check the details on that, to be honest. I can't answer the question, if I'm just to be blunt, because they're quite specific points. So,
okay, so
could include it in the table of actions, Chair.
Yeah.
Well, I would suggest, in the interest of time, we will progress to endorsing and sealing these things, subject to reassurance around the issues that you've raised. So we will seek assurance on those matters, Maynard, and if it's agreed and appropriate, we will then approve the seal. We'll apply the common seal to the contracts. Is everybody comfortable with that? Great. Okay. Fine. Let us move on to our next item, Sharon. Strengthening quality governance through integrated experience reporting.
Diolch, Cadeirydd. Thank you, Chair. Thank you, Winston. So thank you for receiving the report. It's proposing a revised integrated approach to quality governance through developing a unified reporting framework. This is in part in response to statutory and regulation changes, in particular the upcoming listening to people regulations, which will become effective from April of 2026. But also from our previous board discussions as well, where we've acknowledged that the feedback that we received, qualitative and quantitative, is very plentiful, but can be fragmented across multiple systems. It's difficult sometimes to synthesize and to demonstrate the impact as well. And once we have made some progress in that space, I think we've recognised the need for, again, better thematic analysis and trend identification. So with the evolving development of technology, there is a greater ability to provide that analytical and actionable data. So we've proposed a few actions within this paper. Firstly, we want to restructure it, and we want to transform the report into a twice-yearly thematic publication organised around key public issues, using a you said, we did format, really, to evidence our responsiveness and our learning, really, in this space. I think it's important that we coordinate that on it to coincide with your annual report as well, which is in the papers today for information under item 36. And that, too, provides valuable information about the experience of people here in West Wales, but it's also very congruent with what we see ourselves in terms of the feedback that we get directly from our service users as well. And I think what it does do is sort of supports under some of the work that we're doing around our ability to make much of our unscheduled activity more planned or more scheduled, and initiatives that we're developing such as call before we convey and those clinical streaming hubs as well. So I think those are some of the actions that we're taking forward in response to the feedback that we're getting, and it's how we move further faster in that space. And we've got further conversations in the meeting today to discuss that. The second action is just briefly to how we write our reports and how we ensure that we adhere to the STEEP principles and the duty of quality, so that we ensure that we are transparent, we're providing assurance that we give meaningful learning, we ensure that our governance discussions are not only concerned with resolving issues and addressing financial and operational challenges, but we're also improving care holistically as well, and visibly responding to what matters most to our public. We will be reviewing the proposals to review the Listening and Learning Subcommittee and strengthen that so that there's more diverse representation and we can track the journeys through from feedback to improvement to ensure that that learning is embedded. And there's a paper coming to Quality Safety Experience next week around an updated learning framework as well to help us to do that, so that we can develop safe care through continuous learning and promote psychological safety in that space. In terms of transparency, we are looking to develop a bilingual web page so we can share the information that traditionally came to this forum publicly on the website, and we can use digital storytelling and regular citizens engagement forums as well, so we can invite that feedback. So just for reassurance or assurance, whilst the report will come here twice a year, we will be taking the more quality assurance dashboard report into QSEC every meeting, so there will be that continued oversight as well.
Thank you, Sharon. Okay, questions? Anne, I know you want to come in.
Thank you very much, Sharon. And can I just say thank you to Donna, because putting these two reports is bringing life to your report. The data is collected, and the Llais report is, like you said, it's continuing the themes. And Llais now are doing a report twice a year. So they've done their annual report, and this is your second one, isn't it? Yes. So it'll work really well with the dashboard, and I'm just so pleased to see the voice in the paper. You understand? Yeah. So thank you very much, both of you.
So I was going to come, Donna, I was going to come to you now, because I think exactly the same reason, and what we need to do is bring together what we think the experience of patients is, and actually what you might be understanding, to understand whether it's different or whether there's a similarity between what you might find in terms of patient experience and what we are uncovering through our methodologies.
Thank you, Chair. I think for us, one of the ways we're getting patient experience is we're spending time with people in their own communities. So we're using an approach we call Llais Local, because our philosophy is if Mrs Jones spends 98% of her time in her community, she's not going to jump on a bus to get to Carmarthen or Aberystwyth to spend time with us for an event that she doesn't know what it feels like, she doesn't know who's going to be there. So we have to go to communities. So we do dog walking with walking groups, we go to keep fit classes, cookery classes, home education groups, and there we find people are quite often willing to share because they're with their peers and they don't feel that they're so perhaps isolated in telling what's happened. Most people have got a health story to tell us. What we find more difficult is getting them to think about something in the past few years. But certainly we find that there are recurring themes happening in wherever we go, but there is that local nuance on it as well. So we find in one place that the GP surgery is thought of as wonderful, we go to the next place and there are more problems there. And again, I think that's helpful for us to identify what the variation is, why there is that variation, and what we can do to make it more equal throughout the whole region. So I think it's really helpful for us. As I say, most of the information in the report is from engagement, not from our complaints advocacy service, because engagement is what people are talking about in communities, what they feel, what they're experiencing, that they may never ever take through to a formal complaint, but knowing what people are talking about can help prevent the next level of complaints coming through, because if we tackle it at the engagement point, the unhappinesses, as well as the things that are working really well, we can build on that to try to make sure that there are less complaints coming through the system because people have been heard.
Very good. Can I ask, does the Thrice report go to CUSAC?
Not in the full format that it used to come here, but going forward, it will.
Very good.
Yes.
Very good. I mean, I think it's really important that we can, I think you've described that really well. So I think if we can get an early understanding of what patients might not eventually complain about, but what they're unhappy with, because I imagine there's a lot of people who would sit in that category who won't go through a formal complaints process. I think that can help us learn from the experience and do things differently. And if there's any value to us harvesting patient experiences, it's so that we improve what we do. So I'm reassured to know that it will go to CUSAC on a regular basis, because what I want to be assured of is that as we pull together this information, that the quality of that information is of the highest, that it's reliable and valid in terms of the information it's offering, and that we do something differently as a consequence if we discover that the services we're providing are not meeting the needs of the patient. Yeah. And then I'm very comfortable with that as a chair, and I think we are as a board, that everything's been done in the right way. Great. I'm not going to, in the interest of time, I'm going to move us on. And I think bringing the two together is a really helpful thing. Can I move us to Public Services Ombudsman Wales Public Interest Report and annual letter?
Certainly, yeah. Thank you, Chair. So this paper is being presented to Board. It's twofold. Firstly is to consider the findings of the Ombudsman investigation into the cessation of the learning disability LD epilepsy surveys in June 2021 and the Health Board's failure to provide adequate alternative specialist care or communication thereafter. So this resulted in a public interest report being published on the 9th of October of this year, in that the Ombudsman upheld the complaint, identifying maladministration and service failure, and has made formal recommendations for urgent action. And the second part of the report is to receive the Public Service Ombudsman letter for last year, essentially. So just in terms of the public interest report, to update the board, really, we do have a task and finish group that has been established this year, which has been led by one of the assistant directors of nursing for planned and specialist care, to bring that neurology element into this, but also with representation from mental health and learning disabilities and Llais as well, to progress the recommendations within the report. And then medical director and myself also have set up some meetings with the family members of some of the clients with LD epilepsy and SUDEP Action, which is a sudden unexpected death from epilepsy group, to ensure that their views are then considered in the pathway design and to update them really on the progress against the Ombudsman recommendation information going forward. So we did discuss the public interest report verbally at the last QSEC because it was on the same day that the report came out, and assurance was provided that the actions were on track, and a further update is provided via the planned and specialist care group next week to QSEC as well. But just to provide assurance that we, in terms of the first 2 months, the recommendations that were required have been actioned. So we're taking those recommendations seriously and progressing that action. And then in terms of the Ombudsman annual letter, I will take that as read, but happy to respond to any questions.
Thank you, Sharon. I mean, we've had some discussion about this before, and I have to say, Phil and I met with the families of patients earlier in the summer, and frankly, it was harrowing. It was harrowing listening to their experiences and how the service had failed to deliver what they needed. It was harrowing and humbling to hear how much they were doing to safeguard their children in these circumstances. And my anxiety stems from the fact that we allowed it to exist and prevail for a long time. So we knew this service was suboptimal. We knew it was suboptimal. It wasn't being delivered best. And yet it took something from the Ombudsman to make us sit up and realise we needed to do something differently. Well, that's not how this organisation needs to do business. We can't wait for someone else to criticise what we're hearing. It goes back to the very heart of the report we just discussed and the future of patient experience and what we do with that knowledge and information. So it does feel to me there's a lot of learning in this, not just about putting those services right, but how we address the concerns of patients and carers of patients when those services are suboptimal and not being delivered to the standard we would expect. And we can share the blame and disseminate the blame for that, but we all have to take responsibility for this not being what we would want to deliver.
I guess in response to that, Chair, as you say, we've discussed it in this forum, we've discussed it at Quality and Safety, we've discussed it at Executive Team, and I know there was a listening and learning subcommittee meeting last month where the theme was at that point in time around mental health and learning disabilities, and there's a follow-up meeting on Monday, so there's also sharing of that learning as well at different parts of the organisation, so that we make sure that we make changes as a consequence of this report.
Okay. Mark.
I just want to, much like we're all doing, thank the families for sticking with us. They still are engaging with us and meeting with us, which you could think is surprising by how much we've let them down, and we still sense that we're building trust with them, but they are still very much working with us in a positive sense and giving us ideas about what we can do. I think, as I said, there still is a degree of mistrust, but we're committed to working with them. And I just want to, again, apologise to them and thank them for that.
Thank you, Mark. Great. Okay. I'm going to propose what we do is then we take assurance from the arrangements in place for compliance, which have been in way, and I'm conscious they've been underway for a while. They began earlier before the report was published. And we note the proposed arrangements for review of the Public Services Ombudsman's annual letter 24/25. And then we delegate oversight of compliance assurance to the Quality, Safety and Experience Committee. Great, okay, thank you. Okay, shall we move on to our next item, Ceredigion Community Mental Health Referral Pathway. Andrew, you may want to open this before we talk to Warren.
Yes, I'm grateful for the opportunity just to open the paper. I'll take for granted the fact that everybody's read the paper. And I'm conscious that I've got with me today Dr. Warren Lloyd, who's the Associate Medical Director for Mental Health and Learning Disabilities, and this Rebecca Tackle-Purcell, who's the Assistant Director of Nursing for Mental Health and Learning Disabilities as well, to support the conversation. Four things I just wanted to say briefly and introduce the paper. At board in March, we agreed an urgent temporary change to the pathway from primary care into the adult mental health service in Ceredigion. During this time, we've had positive feedback from key stakeholders commenting on the reduced access times for patients, increased service responsiveness, and the improved integration that the change has led to between primary care and mental health, we were forced to make the change on the back of some workforce pressures and challenges that we had that were going to pose us with a significant safety risk for the population there accessing these services. So that feedback has been important. There has been a lot of learning that we've taken and we would like to use now to inform the next steps, both for what we do in Ceredigion, but also to engage on how we might scale up this model across the health board and extending it to cover, apologies, I've got to move the mic, extending it to cover both Pembrokeshire and Carmarthenshire. So to do this would require us to agree today to extend the temporary service change in Ceredigion until the end of March, and also commence a 9-week-long engagement process starting in December that looks to explore the potential impacts and benefits of extending the service across the health board. I don't know if there's anything that my colleagues would like to add before we go into any questions.
Yes, please.
Thank you, Chair. Thank you, Andrew, and thank you, Board, for the opportunity for us to provide a further update and set out the proposal in terms of a wider health board engagement in terms of how we deliver our service, especially in terms of routine referrals. Just to pick up an action following the September board meeting in terms of the ongoing engagement with our primary care colleagues, I just want to express my gratitude to our primary care colleagues in Ceredigion who've set time aside over the last several weeks, both in terms of facilitating joint South and North Ceredigion primary care online meetings for us to attend, and the North Ceredigion face-to-face GP collaborative meeting and the South Ceredigion collaborative meeting online within the last few weeks. That's really enabled us to have further informative and constructive conversation in terms of their experience of the interim urgent contingency plans we had to implement from March following board meeting, and also to allow us to tweak our responses in terms of how we deliver the services both here and now, but also in terms of how we move forwards with the service provision. As Andrew said, there's been overall positive feedback. There's also been areas of concerns that's been raised and that we address, and we hope to do that in a very timely and proactive manner. And we've set out a number of avenues for anyone to contact us if they have any specific concerns in terms of the interim changes in terms of how we manage routine referrals within Ceredigion adult mental health services. We're more than happy to take any further questions in terms of the current arrangements, but also in terms of what we are requesting the board to consider in terms of next steps.
Great. Okay. Thank you very much for that. I have a question. My question is, because on the surface, this would seem like a very logical and progressive thing for us to do. It was born out of necessity, but it looks to me as if it's delivering some positive results for patients and providers as well. But I wonder, Warren, whether we are fully aware of the risks or the potential weaknesses of this process, and whether we have or we can manage those in the future.
Thank you, Chair. Very valid question, and I think therefore the importance in terms of the public engagement over a period of 9 weeks, and that engagement is with all stakeholders, most importantly with our population, individuals with lived experience of our services, our third sector colleagues, and then primary care and the wider system that we engage with, because it's important to listen to their experiences, their views, and then bring that back to board in March, should the board endorse the proposal. I think to add to that, and I'll bring Becky into that, is also the opportunity for us to align this with the strategy in terms of the direction of travel. And I'll hand over to Becky just to talk through those principles and how we think this pathway will align.
Thank you.
Thank you. So I think that we are we're very positive and optimistic about this as a change that we've already tested and want to expand and develop. The new strategy for mental health and well-being across Wales really encourages us to be thinking quite radically really about how our services are set up and moving towards an open access, flexible model that means that access to services is very much self-directed or directed by individuals themselves, and that there's a range of choice and that essentially we're looking at same-day responses to what people need. And I think that we very much recognise that this is a first step for us. Obviously, 111 option 2 has been something that we have begun to embed, and I think we were one of the first health boards to actually fully develop and embed this approach. And I think what's described within the paper and the proposal to look to strengthen and build this service to be our front door for all non-urgent referrals really just takes that a step closer towards that open access model. I think in terms of risks, as with all of the discussions around open access, I think some of the unknown is, you know, are we opening our door to unprecedented demand? I think what we can see from our period of 8 months is that we haven't seen any significant surges in demand from 111 option 2 perspective. We've seen some gentle increase across all of the 3 counties, but nothing overly significant that would give rise to any concerns, I guess, from a demand and capacity perspective. I think the benefits that we are seeing are that the work that we're doing from a community mental health perspective is very much being targeted then at more complexity, at more urgent need, and therefore it just helps us to be able to use the resource that we've got in a more effective way. And also it puts individuals very much in control of their access, that rather than waiting for a referral, sitting and being on a waiting list, that they're able to make choices about when they make a call. And you know, in terms of transport, it helps to eliminate some of those challenges. I think there are considerations. Not everyone is going to be telephone contact through 111 option 2 is not necessarily a model that's going to fit for everybody and communication needs. And I think we've got to be flexible in terms of our approach and be considerate of all of those additional needs too. And I think that the engagement piece will really help us to understand the degree of flexibility that we may need to build into that. What I would also like to say is that the work that we've been doing has been co-produced, so we do have people with lived experience that are sitting alongside us and regularly reviewing and monitoring and working on plans. I think that the engagement with GPs and with primary care has been critical, and also our engagement with population has also been really important. And we're not seeing any significant concerns raised in terms of our quality metrics. We've not seen any great variation in that. So it feels very measured for us to be taking the steps to extend this further and to be re-evaluating and making some further decisions in March.
Great. I'm going to take just a few comments and then we're going to close the item and move on. Mark, I'm going to come to you. Then.
Thanks, Neil. I just want to thank Becky and Warren. I think, as we know, this was an urgent service change, which isn't something that we ever wish to undertake. But the importance of this has been clinically led and co-produced, and there's been a lot of engagement across primary care and with all our partners. And I think what we can see is that this is a transformative change with lots of significant benefits, which is why we want to now extend it. And the rest of Wales is looking at this because they believe that this is something that they would wish to implement as well. So I want to thank you for this, and to really, this is indicative of how we should introduce change, apart from its urgent nature, is that it's clinically led, it's co-produced, and it's transformative.
Thank you. Very well put. Anne, and then Ewan, and then Michael.
Thank you, Chair. Thank you both. My question, as you would expect, is around staff. They were really involved in your change in Ceredigion. They had to be, and that's what's actually driven this to be the best it can be at this time. And like I said, there's more to do. Do you feel the staff in Carmarthenshire and Pembrokeshire would be willing to come on board as effectively as Ceredigion did? Because you're looking at a consultation of 9 weeks, but you didn't mention the staff in it. And as a union rep, that's where I come from. And the other part of this is once it's in place, at the moment there's 50 odd patients sitting in A&E because it's a place of safety. Will this be able to reduce some of those numbers going in the future?
Right, hang on to your, keep your powder dry, hang on to your response. We'll find out if there's any more questions for you to come to first. Ewan.
Diolch, Cadeirydd. No, thanks to Owen and Becky, because I know through the Mental Health Committee, you've been really great in terms of sharing the information, in terms of what's happening on the ground, as it were, and in terms of co-production, as you mentioned, and as colleagues have mentioned. Similar to Anne's point around staffing, I'd be interested to kind of tease out from yourselves directly, is there enough capacity in terms of the staffing currently that we have and the expertise to roll this out in terms of what we're looking at? Because I know sometimes we talk about a committee, some of the challenges around unfilled posts and vacancies, which are long-standing. And I think, you know, it's great in terms of this innovation and the fact that we're working with our communities and other partners, but have we got the capacity to do it in terms of the skill base? So that's a challenge I'd just like to hear.
Okay, thank you. And then Michael.
Yes, thank you. I'm very happy with the report and love the use of the word co-production. I was just curious of the issue about engagement as opposed to consultation. Could somebody maybe enlighten me on that?
Spoken like a true lawyer. Into the detail. Becky, Warren, if you'd like to come back on those, that would be great.
Thank you, Chair, and thank you very much for the questions, and thank you for the reference in terms of the co-production and our approach. And absolutely, it's a given for us when we say we'll engage, that's our staff. They're essential to delivering our services day in, day out. We've got a very committed staffing team. And managing clinical acuity and pressures day in, day out, and therefore essential in supporting us, both in terms of listening to their voices, but also in terms of how we can drive change and can make sure that this change is sustainable and it is a change that is endorsed by our staff going forwards. As important as our lived experience colleagues, and staff will have lived experience, and so will our public. So it's making sure we capture all those views and be attentive to that in terms of how we take the changes further forward in terms of our routine referrals in adult mental health services. In terms of sustainability, one of the drivers for the change is to ensure that the service is more sustainable in how we deliver it, especially focus in terms of our secondary care provision, to make sure that we can provide more timely secondary care, that we are compliant with the measure, part 2 of the measure, but more importantly, that individual will have access to the right service at the right time, with the right individual that can support their needs. And that aligns with the strategy and direction of travel. We've learned a lot through from 2022 in terms of the 111 option 2, in terms of our service. And this change will allow us to further enhance how we deliver our 111 option 2 service. As Becky's referenced, we need to expand that service to be not just a telephone contact, but in terms of what are the other opportunities to engage in that service in terms of that important first conversation to establish the here and now needs and how those needs can be met, whether that's within health services and or with our partners. So that's going to be a very important consideration in terms of how we do that. And therefore, the proposal is in terms of a phased approach. So it won't be day one start across the whole of the clinical care group in terms of Ceredigion, Pembrokeshire and Carmarthenshire. It's starting with or building on what we've done in Ceredigion, and then it's phasing that over time across the other 2 counties. And the reason for that is to make sure we can do it in a sustainable way, and we learn the lessons as we go, because we may have an idea of the starting point, but as we progress with that plan, there will be a lot of learning, and that will be something we can then incorporate across the whole system in time. I'll pause there because Becky's made some notes, and I'm sure she'll Want to add something?
Yes, I think just going through the questions, so in terms of staff engagement, so I think one option 2 would be our key team that would be affected by this change, and that service is actually a Hywel Dda wide service, so the fact that we're already doing this in Ceredigion, it's effectively the same group of people that we would be expecting to sort of be part of the change across the other 2 counties, so they're all already sort of in that change process. The capacity challenge, I think, is one for us to continue to monitor. So we're currently taking around 1,500 calls a month through 111 option 2, but being able to maintain our standard around response rates, which I think is within 2 minutes of a call being made. So I think we've got metrics in place to help us to be able to judge and to monitor that, and we would need to be looking at the need to potentially shift resource if we see a huge spike in demand. In terms of A&E presentations, so this is a model that really focuses on that early intervention and early access, which would lead us to think that actually if we can work with people at that earliest point of need, that hopefully that would have an impact on their recovery at a much sooner point. So we would hopefully expect to see reductions in urgent presentations, which then has a knock-on effect on A&E presentations, and we've got other kind of work streams that are also focused on that as a particular challenge and priority for us as well. The question around engagement rather than consultation, I'm not sure whether Alwena might want to take that.
Actually, I'm going to bring Alwena in to...
Thank you. Diolch, Cadeirydd, diolch, Gyfeillion. Just to reassure Michael on the point of consultation versus engagement, this is what we're seeing as a pathway change as opposed to a service change. And we're looking to, well, we have been working with colleagues in Llais and with West Wales Action for Mental Health around how do we seek the views of service users to look at what that impact would be, because from a patient perspective, the optimal route, as we understand it, is through that 111 option 2 to start with. So it's reinforcing that route and enabling people to provide feedback on that pathway change as opposed to service change. And just to note that the 9 weeks rather than 8 weeks in what we were recommending is to take account of that Christmas period so that we can really enable people to have a view in there.
Great. I'm going to take us straight to recommendations because I'm conscious of time. So first of all, we'd like to acknowledge the work that's been done in relation to evaluating the change currently. It all seems to have been a very positive, notwithstanding I think we're aware of the risks. It seems to have had a positive impact. And then am I assured that everybody is supportive of extending the temporary period service change until March 2026? Yeah, and approve the launch of the 9-week engagement period, notwithstanding what Alwyn has just said about the period over Christmas, that's fine, and improve the suggestion that we receive the engagement outcome in March 2026 when we will agree next steps at that point. Great, okay. Warren and Becky, thank you very much. That's been enormously helpful for us to understand the detail of it, because often it's quite difficult just to assume that from the papers we receive. So thank you very much for your contribution. Enormously helpful.
Thank you, Chair. Thank you, Board.
Great. I'm conscious we are at lunchtime, but I would like to take Ardiana's paper on the annual report now, as opposed to leave it after lunch, because I'd like to begin when we are re-energised with our conversation around UAE. So, Ardiana.
Okay, diolch yn fawr. Then I'll hope I will not bring down further the levels of energy before lunch. But thank you. I'm delighted to be presenting the annual Director of Public Health report, which this year is titled Prevention of Ill Health, Everyone in Every Service, All the Time, a 24/7 prevention model. This is both my own personal reflection on how we as a health board can do better prevention, but it's also a call to action for us all here on achieving that. It comes at a time, as we've discussed all morning, where the greatest need, the highest demand and the highest pressures on NHS. We see every day the impact of preventable illness and the health inequality across Hywel Dda. We heard, even from Jeff's presentation now, that our colleagues, our clinicians, deliver high-quality, person-centered care. However, we very often meet our patients too late in the pathway when prevention has already failed. And the data is stark. We've got an over 12-year healthy life expectancy gap for men and over 10-year for women. And this presents thousands of lives that are affected by preventable ill health, loss of productivity, and pose every further demand on our stretched services. So the 24/7 model builds on 3 interlinked priorities that are most effective at tackling all these issues that are interlinked. Focus on the 20% of the population that are most deprived, where the health risks and the outcomes are poorest. Tackle systematically the 4 key modifiable risk factors: smoking, poor nutrition, harmful alcohol use, and physical activity, which present over a third of behaviors that drive over a third of preventable illness. And target 7 priority health areas, which are the cancer, cardiovascular disease, respiratory, diabetes, mental health, preventable illness in children, young people, and preventable illness in older people. And if I can just bring this to life with just a couple of examples. Tooth decay is the leading cause of hospitalizations in our children under the age 10, yet it is entirely almost preventable. By tackling very easy and very feasible actions that are preventable, such as facilitated toothbrushing, healthier eating, we can reduce burden of illness and burden in our NHS. With 1 in 4 of our residents that are aged 65 and older, through preventative actions such as physical activity, social connection, early interventions such as hearing, participation in community activities, we can prevent falls and we can delay onset of dementia. By delaying onset of dementia by only a few years, we can reduce by half the burden of dementia in our population. So my key recommendations are feasible, ambitious, but are also enable us to embed prevention at every stage in life. And they stretch from system-wide preventions, that every service will integrate prevention actions into the annual planning cycle, supported by the 24/7 checklist and a review process. This will ensure that prevention is not left to chance, but it becomes a measurable and routine part of care that we deliver. And we will enhance our existing preventative programs from screening and immunization through to health coaching and community health workers for our most deprived communities. Workforce engagement, so we will have a comprehensive program of staff engagement and training to make every contact count, a core competency that we give agency to all our staff to be able to offer appropriately evidence-based brief advice or referral. Leadership and accountability, we will empower us, our leaders, our managers, to embed prevention through the 24/7 dashboard, which is in development, to monitor progress and outcomes. Sustainable funding with prevention cannot be delivered by goodwill alone, as we've discussed this morning. I recommend a 3-year invest to save approach that will enhance our resources towards prevention, and that very often referred to upstream intervention. And equity in data, we'll integrate our bespoke health equity impact assessment into the strategic planning and budgeting. Hugh mentioned earlier that we've developed our bespoke population health domain into our escalation framework. So all these under the umbrella of targeted programs that are enhancing and enabling us to use intelligence, for instance, for our primary care clusters, to target action by recognizing the interdependencies and intersectionality of our population that are affected by the deprivation. So, in summary, I do want to emphasize that prevention is not a separate agenda for us. It is the essence of good medicine, good management, and good stewardship of our public resources. So I'm asking the board to endorse this report and its recommendations, to embed prevention as the foundation of care delivery we can deliver in our commitment for health equity, system sustainability, and well-being of our population. So, diolch yn fawr. Thanks very much.
Thank you very much. Thoughts, colleagues? I mean, you can take it as read. We are highly supportive of everything that you're describing. If I had one query, it reads like a proposition, not an annual report. So annual report usually says, this is what we've done. These are the glorious things we've done over the last 12 months and what we've delivered in terms of impact. Whereas I think this is a proposition for how we need to be different in the future. So you may want to think that in terms of how you present it.
Yes.
But in principle, the things you're driving is absolutely sound, in my view.
If I come just, yes, very conscious of that and almost deliberately move to that. However, it does include examples of what we've done. And it has been a sort of a culmination of work from about the past 9 months with all colleagues across the health board.
Very good. Okay. Hugh, did you want to come in?
Yeah, thank you, Chair. Just to add and I guess reflect on the link between the finance 3-year roadmap and the work that Ardiana's suggesting here. Clearly, we are in a very constrained environment at this stage. So what we do need to be sure of is that we can measure the impact of the interventions we're making very clearly, so we can understand how we're addressing the prevalence increases that I mentioned in my paper. And we also need to make sure that we are tracking the immediate impact we could have on our system in the very short term, in the medium term and the longer term, because we are going to have to redirect resources from other parts of the system in order to fund this on a sustainable basis. It's the right direction of travel. We're a population health system and we need to reflect that. But that money will have to come from somewhere.
Yeah.
And therefore, this needs to have an impact in order to pay for itself in a relatively short time, and then we can expand into further upstream interventions that we can make and broaden out from that to have a longer term impact.
Yeah, I completely agree with that. Yeah. I mean, we do need to do that, but we also have to have a degree of faith that these are absolutely the right things for us to do in the long term, and inevitably there will always be risks when we make that kind of leap. We have to be courageous in this space. We are not going to deliver the kind of changes to our demand unless we start to invest in some of these areas and do it early and quickly and sometimes at risk, because I suspect some things will work and some things won't. And as long as we continually learn in this place, that's the most important thing.
Just the same as with any other clinical service, Chair. Some things do work, however, based on evidence where majority it will work, and the sort of the limitations of prevention is that it's the unseen. You do not anymore see, but as Hugh said, we can follow the trends and we can follow the impact.
Very good. Okay, Bill.
So yeah, diolch, Cadeirydd. So really, we've seen this building up to this moment over the last 9 months. And we've been talking about the importance of preventing ill health and improving population health all morning. And I think we're desperate to push this forward, and find ways to push it forward. The thing that was in my mind was that how much this should be a partnership endeavour. Because the consequences is we're talking about the consequences for our services, and there's an existential concern about our own kind of services. But actually, if this was to be pushed, actually the impact on the whole of the public sector would be very significant. And I therefore wondered if the rest of the public sector sort of sees that in the way that we're starting to see that.
So I absolutely think that
Yeah.
this is one of those initiatives where we will only deliver through our relationships.
Yeah.
There might be other parties, but actually it's the strength of that relationship, the substance of that relationship that will allow us to deliver this in the long term. Because we have relatively little control. We have lots of ideas and thrust and compelling arguments, but we have relatively little control unless we can work through our relationships with others inside this space. So I think that's essential. I'm going to come to Michael, and then I'll come back to you, Ardiana, and then I'm going to pull it together. I'm going to close the item.
Thank you, Chair. Yeah, my comment really is on the back of the partnership comment that you just made there at the moment. Really good to see making every contact count included as a core competency across the workforce. I was just reflecting, are there any opportunities to extend that MEC training to other sections of the workforce, given that there will be trusted professionals within local authorities and even more so voluntary and community sector that will have day-to-day interactions that are not part of the traditional health and care workforce, if you like, but with the confidence to have some of these conversations around health behaviours, which, you know, let's remind ourselves, 30% of someone's health in the main is down to these health behaviours. It feels like there's an opportunity there we should grasp. Now, I appreciate, coming back to Hugh's point, that there may be budgetary implications there, but we may want to have a discussion as a partnership about what funds, such as the Regional Integration Fund, we may want to draw down from to get as much bang for our buck as possible.
Yeah.
Very good point. Yeah.
Great. Thanks very much all for comments. So on the partnership and on not doing it alone. So this is the model that is primarily focused to us as a health board, but it builds on the cornerstone and the foundation, which is a social model for health, which is much more of our partnership approach, through which we're driving, yes, with all of our partners and communities and voluntary sector, in addition to the factors that we do as a health board, as Phil is talking about, the communities, the voluntary sector. Expansion of Make Every Contact Count, absolutely that's the intention. We've already done it or initiated with Carmarthenshire PSB. For instance, we've talked about fire service. They are in people's homes, particularly in older people's homes. There is evidence of reducing falls through that Make Every Contact Count. And it will be the way that we envisage and that we've already initiated, for instance, like with children, young people, but what will be, for instance, the older people's group under that 7 umbrella, that all those partners from communities, voluntary, primary care, our secondary care, will come together and see what are the best ways to reduce burden earlier in the phases of people facing those health risks.
Great. I'm going to close the item there. I think you can take that we're endorsing the report. I think it's profoundly important. I don't think we're talking about it enough.
Yeah.
So I think it's great that we've had the conversation here, but this needs to be a regular conversation. So we think as a board in a very public health focused kind of way, and that's not saying that we're not doing that currently, but our focus is very much upon other aspects of what we're trying to deliver across the board. So, and I think we need to come back to it regularly within a development environment as well as a board, Ardiana, because it's something that we've just got to all buy into, and we've got to lend our support to it and our effort and our energy to make this happen.
Great. Thank you.
Thank you very much. Let's break for lunch, and we'll reconvene in around 25 minutes' time. Thank you, folks, for coming back so quickly following our lunch break. We've still got quite a number of substantive items to discuss on our agenda. I'm really pleased to see so many clinicians in the room. That's a rare experience at board. So thank you very much for finding the time to attend today. I'm going to open the next item, and then I'm going to hand over to Andrew to take forward. So inevitably, you're here because we want to draw on your knowledge and expertise in terms of understanding the situation within UAE, but more importantly for you to share with us your thoughts and ideas of how we move forward from this point. Karen's already come to talk to us a while back, and we had a very fruitful, useful conversation about how we could move forward, but we feel as if the reason why we're discussing it on the board today is because we feel it's such an urgent, important issue for us to grip and address as a health board, but also as a board, that actually we're hoping that today we can forge ahead through this conversation and decide on some very clear kind of direction of travel in terms of moving forward. I'm not for a moment thinking that's going to be easy, or that we will have resolved issues over the course of the next 30 or 40 minutes, but I am hoping that that we can all begin from a position where we have clarity on what we think we need to do next and how we need to press ahead and do that. And it's partly driven by the fact that the reason why we put it onto the agenda is that we feel at one level deeply conflicted about what we're seeing inside accident and emergency. We see clinicians who are dedicated and fully committed to delivering the best possible service they can. We see environments that often appear as complete chaos. I'm sure there's a level of pattern and organisation to that chaos, but they present as chaos. So managing to work in that environment must be incredibly difficult and challenging. And we know that it's limited, it's kind of determined often by resource, by environment, by circumstance, and inevitably by the demand that's being placed on these services from the wider public. And then on the other hand, we hear patient experience, and there are some patient experiences that are exceptional and demonstrate this system working at an optimal level. And then there's other patient experiences which are so poor and so below what we would want to offer as a health board, as I'm sure you as a clinical community. So I think, bearing all those things in mind, I think what we wanted to do is just have a more fulsome conversation about what that means and what we might be able to do about it. And I suppose as a board, we are trusting in your perception and your expertise and your knowledge and your insight to guide us in this endeavour. So I'm going to hand over to Andrew, and then we'll take it from there. Thank you, Andrew.
Diolch, Cadeirydd. And you'll be pleased now, I'm going to be brief. There's just a few points I wanted to make, but I think it's far more important we hear from our colleagues that are here today. So firstly, I'm really grateful to the board for inviting some of our senior clinical leads and our senior service managers here today to support us with an open and transparent discussion around the challenges we have in delivering the consistency of quality, experience and access to our urgent emergency care services that we would all aspire to. I know we've discussed earlier in the performance aspect of the board some of the performance metrics around urgent and emergency care, and there is a paper I know that supports this item, but I'm not really going to delve too far into that. I was going to leave that there as background information and assume that we've taken that. I think the key message for me from all of that information, though, is that what it points to and highlights is that there's a real inconsistency in how we perform, and that can be down to, that can even be a patient presenting with the same presentation clinically on different days of the week and getting very different experience and service from us. And that's not through any fault of the individuals involved, because one day we'll do it very, very well and another day it will be more challenged, but it's more an example of the conditions and challenges that there are around the delivery of those services. The opportunity, I think, to share today in an open way what it feels like from a patient perspective and for our staff in working in this space feels like a really important moment for us, given the focus we have as a board and an organisation on wanting to improve our services in this space. It's a real priority for us, and I think it feels like a real important moment for us to hear that as we go into winter. And on that front, I'd like to take this opportunity to give a real heartfelt thanks to all of our staff who are working tirelessly across the system to deliver the highest quality of care, often in the most difficult of circumstances. Very, very grateful for everything they do every day in that space. So, and just finally, before I hand over to Peter, who's playing point and will introduce our colleagues and then move us into the session and the discussion, I also just wanted to offer special thanks to the communications team as well, who have worked miracles over the last 48 hours to help pull together some of the material you're now going to see and will be shared with you through the conversation. So thank you for the opportunity, and hopefully I'll hand over to my colleagues who will do a far better job of explaining the challenges and the solutions that we face in this space.
Thank you, Andrew.
Thanks, Andrew, and again, re-echo the thanks to the board for allowing us this time in what is a busy agenda, I'm sure, in terms of getting that sort of clinical voice heard and understanding how these guys work every day and what they have to work in every day. So I'm going to hand over to Nerys Lewis, who is the Senior Nurse Manager at Glangwili, and who has pulled together a huge amount of people into making up the video, with the thanks to our comms team for pulling that together. But Nerys, over to you really in terms of the video and where you want to take us.
Good afternoon, everyone. Thank you. I want to thank you as well for giving us the opportunity to come and speak today.
Nerys, pull the microphone towards you.
Oh, sorry. Sorry, apologies.
Fantastic.
I didn't want to be the only person here today speaking. I wanted the staff on the floor as well to have a voice. We've got 11 staff members. I know they've narrowed it down, but I think you need to hear everybody's experience of working in the environment we are currently working in. So I think if we play that first, and then we can go through then any questions or anything to go through. Yeah.
Eithom ni holi sawl un o'n staff adran argyfwng arbennig. Beth oedd diwrnod da a diwrnod dim cweit mor dda yn edrych fel iddyn nhw?
So diwrnod dda yn A&E yw pryd mae dyn ni digon o staff, pawb yn cydweithio'n dda fel tîm, a mae dyn ni digon o llefydd i gweld pobl sy'n eisiau bod ma. A wedyn diwrnod gwael yw os mae pobl pob man, dim digon o staff a jyst yn galed fel a wedyn.
A bad day would be when I walk in and walk through the waiting area and it's full of patients and there's no spare seats and you think, oh gosh, what's going to happen today? And for me personally, a good day is if someone comes and asks a question like, could I move my annual leave? Could I swap a shift? And if I'm able to say yes, then that turns it into a good day.
What is a good day in A&E? A good day in A&E is when we have a full number of staff. Our staff is fully available, both at the nursing level and at the doctor's level. In addition to this, there's places to examine and see the patients, there's enough cubicles. And for that to happen, we need good flow. So that means we need those patients that we see in A&E to be able to flow into the other sides of the hospital. A bad day in A&E is when we have low number of staff because of many issues, is when we have no flow, and is when we have no places to examine the patients. Now, the problem with flow stems outside of the hospital and within the hospital realm. For outside of the hospital, it starts in primary care, in the pathways we have outside, and inside the hospital, it starts with the availability of beds on the wards, and at the same time, how many of these beds can be available when we discharge patients from the hospital.
A good day in A&E looks like minimal corridor care nursing, good staffing levels, when the teams are able to work together, including different specialities. Bad day in A&E, just minimal staff, which we're experiencing a lot recently. No patient flow throughout the department, but you just keep getting patients in through the main doors. Barriers through other specialities when they're not willing to take people.
Bad day in the department is when you walk into the department and there's trolleys everywhere, there's patients around the bay who've been there overnight, patients waiting in the waiting room for hours, waiting to be seen or waiting for a plan or for flow. When you walk in and there's no privacy or dignity being able to be provided because of corridor care, because staffing levels aren't adequate to match what we need, and there's no physical space to move.
Consider a good day in A&E to look like when there is ample space for patients to basically be housed. If there's good flow within the entire hospital, meaning that we can actually admit the patients that attend my A&E department, and that there's no prolonged stays within the department, thereby making sure that transition of care happens all throughout the patient's journey.
On a good day, mae bethau yn iawn pan mae staff i gael a nwyddau, a pan mae dim llawer o bobl dy lle. Hefyd, on a bad day, y gwych beth wedys i nawr, pan mae staff i gael nwyddau a mae ormod o bobl dy lle, so chi'n gwneud y gwaith yn iawn.
Diwrnod da yn yr A&E, le mae pawb yn gweithio da'i gilydd, mae'r ambulances yn cael eu hando drosto yn fuan mewn i'r A&E department. Patients yn cael eu transfero i'r wards yn gloi. Just yn cael y patients mewn ar yr ambulance yn sâl, maen nhw yn gallu cerdded mewn o'r gymuned hefyd. Felly mae na beth yw dydd eitha ddim mor dda yn yr A&E department.
A good day in A&E would be when there's not many patients coming through the door. It can be quite relentless most days, with over maybe 100 on the screen. When there's ambulances coming in every 5 minutes or so, it can be quite overwhelming. People asking how long, we honestly don't know, we can't tell them, and that's quite frustrating for us.
For the physio and OT teams, a good day looks like being able to access our patients in a timely manner, so we try and get to our referrals within an hour. If they're medically fit and ready for discharge, on a good day, we really strive to complete person-centred, strength-based assessments, trying to get patients out of A&E to their homes, which is the safest place for them. Bad day for us, we have significant staffing challenges at the moment, so that looks like delays across the board, delays in getting to patients, and sometimes patients are waiting overnight for therapy assessments because we just don't have the staff to get to them.
So what can be really challenging for us is because it's such a busy department, medicines often go missing. So to kind of help overcome this, it can really help when patients bring in their own medicines from home when they come into hospital. And then we work hard with the department to try and order the medicines and find them if they're missing, to make sure the patients get everything that they need on time.
Diolch am wrando.
Okay, so I think as an emergency department team, our priority is always to provide safe, dignified care in the right environment. I think from what you hear, they're describing patients in surge areas and corridor care. That is not the care we want to provide. Flow is very challenging for us, flow into the department and the flow out. Patients are attending ED where other appropriate services would help them best. They don't need to attend ED, which is challenging for us. And not having a 7-day working in place for patients to be able to access these services is impacting massively on the ED department. From a working together perspective at Glangwili, we are working as a whole system to manage the unprecedented demand and risk. And we do want to be clear, we do not accept corridor care, surge areas or boarding as our standard of patient care. That is not the quality, not the care we want to provide our patients. It is really challenging when we've got the demand in ED. We're also holding the risk in the community. We can't have ambulances outside. We can't have patients sat in waiting rooms. So on days that is the only option we have is to surge and to put patients in areas that they shouldn't be, to try and maintain their safety. And it is really challenging to provide the quality of care that we want to provide and the patient experience that we want to give our patients. And Anna, with anything else? Yeah.
So, Prynawn da pawb, Clive yw'r enw fi. I'm Clive Weston. I'm one of the acute physicians based in Glangwili, but I'm actually a very old physician who retired and returned. One of the roles I have is to try and investigate complaints and concerns that come in. And I've been asked to present a case that demonstrates that things can go right and that things sometimes don't go right. Just to give a flavour of the sort of thing that I respond to is this, part of a complaint that came in to essentially said that a person's mother had been admitted to the emergency department and been left sitting in a chair overnight. This is wholly inappropriate for a patient of her age and condition, the complainant said, and I was asked to comment on that. And I think, as Nerys would have said, I think a comment that it is unreasonable to manage any patient who needs hospital admission and nursing care in a chair within the emergency department through the night, that is unreasonable. More robust, less frail people probably can tolerate sitting in a chair overnight than weaker, more frail people can. And a person in their 90s with significant weight loss and an underlying cancer, as was the case here, would fall into the second category. It's always difficult to present cases like this without sounding as though one is expecting an answer straight away, shroud waving, just dumping the problem and walking away. And I do hope very much you're not going to get that impression from us. This is the case I felt I should present to you. I have the permission of the affected individuals to present this case. So a person with multiple previous operations, medical and psychological problems attended the emergency department with vomiting and abdominal pain, symptoms that had suggested an upper gastrointestinal bleed. And the initial care was extremely good. Within an hour of arrival, they had had nurse triage, so they'd been assessed. They'd had their observations of blood pressure and so forth assessed. A cannula had been put in a vein. Blood had been obtained and sent for analysis. Very rapidly, they had had an emergency medical doctor assess them. The working diagnosis was confirmed as a symptomatic anemia because of an upper GI bleed. They were referred for admission to the on-call medical team, and while waiting for that, blood had been sent for cross-matching, fluids had been written up. All of this done within 2 hours on a busy Friday night. They were hemodynamically stable, by which I mean they weren't in shock. Blood pressure was reasonable. And because of that reason, they didn't need to be in the resuscitation area for those 3 beds or trolleys. And so they were placed in rooms 7 and 8. And those of you who know the emergency department know that this is a room that used to be 2 cubicles that would normally have 2 beds in it, knocked together, and there are chairs that will accommodate 6 patients. And so she was placed in this shared seating area within the emergency department to receive the intravenous fluid appropriately. Blood became available, and at 1:30 in the morning, they started the first of their blood transfusions. And again, that's fairly quick, within 6.5 hours of arrival. Of course, having a blood transfusion means that you need that little bit of added nursing observation to make sure there isn't any reaction to the blood, so more observations than perhaps would otherwise be the case. At 4:00 in the morning, the overnight medical team came to formally examine and assess her, and she would have been moved out into the assessment cubicle that was then available and back into room 7 and 8 thereafterwards. And then at 9:00 in the morning, the consultant physician on duty on that Saturday morning came to assess the patient. Observations were stable after the transfusion, vomiting had stopped, they used an adequate, validated risk scoring system which determined that she was unsafe to be discharged home and needed to have further inpatient management. All of that as per the National Institute's guidance for care. And a decision was made that she didn't need an emergency upper gastrointestinal endoscopy. She didn't need an OGD, and I'll call that an endoscopy from now on. So she didn't need the magic eye test to look for a bleeding point within the gullet or the stomach. And she didn't need it as an emergency because the blood pressure was all right and the blood count remained good. And so the decision was made that she should be admitted into the hospital to go on to the next routine endoscopy list, which is a Monday morning. At about 1:45 or 1:50 that Saturday afternoon, she wanted to go home and went to one of the nurses asking to self-discharge, but she was dissuaded from doing so. Things remained stable, but she remained in the emergency department, sat in rooms 7 and 8. And on the Sunday morning, the medical registrar, as they should, came and did a review, mentioned that she continued to have some abdominal pain for which she was requiring analgesia, vomiting had stopped, observations were stable, and therefore the plan remained the same, to stay in, to have the endoscopy on the Monday. And then on the Sunday afternoon, in the ensuite toilet on the side of that chair space, she had an unwitnessed collapse, leading to a CT scans of abdomen and head that were essentially normal. But she was then moved to a trolley in the waiting areas within the emergency department. So she moved on to a trolley in the emergency department, and then in the evening of the Sunday was moved to the clinical decision unit, having spent 48 hours in the emergency department. She was what we call boarded, and you'll have heard of that a few times by now. In other words, she was placed in a bed, so in a more comfortable environment, in a bed, nursed by nurses on that ward, but in what I, in the previous version of the slides, had described as a thoroughfare, but I think we decided to describe it as a corridor, because I think most people would recognise it as that. The consultant who reviewed her on that Monday morning made a point of saying that they felt unable to perform a full physical examination as they would normally have done because she was in a public area. At that stage, she was so-called nil by mouth. She was receiving nothing by mouth in order to be ready for the endoscopy. Because of all the previous procedures and operations she'd had, venous access was difficult, a cannula had come out. They had to get one of the anaesthetists to come down to place a cannula. And then the endoscopy was not performed that day. It's really unclear precisely the order in which things happened here, but it looks as though a series of patients, I call them cases, these are people, a series of patients had accumulated over the weekend, which when added to the routine planned list on the Monday, meant that other cases, other people, took priority over her because she was hemodynamically stable. There is a note in the typewritten nursing notes from one of the nursing staff on duty saying that they had asked whether, as a room had become available on that unit, could they move this lady into it? And their senior colleague felt a different patient should be moved into that area. So she remained in the boarded area on that unit. She was mobile, she was self-caring. On the Tuesday morning, various phone calls took place. The confirmation that she was on the Tuesday list was given. Consent was obtained from her that she was happy to go ahead with this. And then on the Tuesday morning, another phone call down to the unit saying that the endoscopy had been postponed because an emergency case had been admitted. At which point, perhaps unsurprisingly, she felt that she much rather would be at home. And rather than asking her to sign a form to declare that she was discharging herself against medical advice, a very reasonable medical note was made. We asked them to stay in hospital so the endoscopy can be arranged during the hospital stay, in other words, on the Thursday. However, they don't want to stay longer and they wish to go home. The plan was put in place that blood tests would be performed in a week's time. A review of all the blood tests for the previous 2 to 3 days showed that it hadn't continued to fall after the transfusion. And a review of all the observations, 15 different sets of blood pressure and pulse over the previous 48 hours, had all shown stability. And so 4 days after their arrival, having had this tremendously good, rapid, timely care within a busy emergency department, they left with that. I was asked, I think Karen said, do a sliding door thing. How could it have been different? And I don't think this particular hospital admission could have been avoided. The scoring system that was used clearly stated that admission was required. The national guideline does suggest that if you are hemodynamically unstable, if you're in shock, you get blood transfusion, you call in a duty endoscopist, the nursing staff, and the necessary ODAs to actually man the service that would allow an emergency endoscopy. For those who don't require that, the guidance suggests that you should have an OGD, an endoscopy, within 24 hours. That's a routine list every day of the week in order to achieve that. And perhaps if we had that, then on the Saturday, the procedure would have been done, and if there was a bleeding point to find, it might have been found. That might have allowed endoscopic treatment, it might have allowed a better risk assessment as to whether they would have had future risks, it might have allowed early discharge with hot clinic review. If there had been an electronic system, almost like an aircraft booking system, where you could find out where in the list and how many patients are waiting to have the endoscopy, that might have helped with any confusion. And perhaps the boarding might have taken place in a gastroenterology specialty ward rather than on the clinical decision unit. But then do we have enough spaces in the gastroenterology ward for the accumulation of patients over the weekend? And I would just, the thing that I reflected on, because there has been a concern raised about the care provided to this patient. Would this patient have been more likely to remain in hospital to have the endoscopy on the Thursday if their experiences of the previous 4 days had been more restful and more comfortable and more dignified? And perhaps when they had said, I want to go home now, perhaps the medical staff would have been more assertive in saying to them, no, you really must stay, rather than perhaps empathizing to the point of colluding with care that was not of the best, and allowing, that's the wrong word, seeing the person make this decision and sharing the decision that they could go home at that point. Anyway, I think that is a blank slide, and we will no doubt talk about these things. Thank you.
Thank you for that, Clive, and I think it's a moment, isn't it, for us to take in terms of the services and the environments in which our staff are working and our patients are being cared for. I think the best thing to do now, Chair, is for us to hand over to you for questions and thoughts, and then we will work with you in terms of the answers to those questions.
Okay, thank you very much for both the vox pop kind of involvement of staff inside the unit. I thought it's very helpful and always really insightful, and also for the example you provided, the case study you provided. As you read it, your heart sinks lower and lower and lower, thinking nobody is specifically to blame for this. It just feels a whole series of systems issues, pulls, pushes, considerations. Nobody's desperately trying to be unhelpful or not put the patient first or do any of those things, but somehow the system suboptimally is allowing this kind of reaction. So somebody leaves probably worse than when they came, or not as well as they could be under the right circumstances. So thank you for providing that example. Very helpful. Yes, please, Mark. Do you want to come in?
Yeah, thanks. Thanks,
Okay.
Chair. Thanks, everybody, for coming. I think the point I want to make is that there's a risk maybe we think that's an unusual experience. But I worked in upper GI surgery for many years, and I would say that's the norm. That is not an unusual example. I think you would agree with me. That's the level of care that we are providing to the majority of our patients, not to a minority, certainly in this circumstance. And that clearly is very demoralizing for our staff. And this is what's become the norm. And what's really striking, isn't it, about what we've described is what staff describe as a good day. This isn't an amazing day where they've got paid and they've had wonderful things happen to them. This is just we have enough staff, we can treat patients in an appropriate environment and do the job that we are trained to do, which is a really, real basic ask, I think, is that staff just want to be able to take care of patients in an appropriate environment. So I think what would be, I know we are going to have a broader discussion, but would be, I suppose, discussing with our clinicians, what are the solutions? Everybody is really experienced, understands the issues, the resource constraints, the constraints that we have in healthcare. But what are the other solutions? Because there are many solutions that have been put in place, many attempts to reduce admissions, to discharge patients more appropriately, to have different types of clinicians to avoid admission. What else do you, as experts in your fields, believe that we can do and that we as a board could support?
Good question. Okay, hold on to that before we come back to that. Rodri.
Yeah, thank you. And you know what, that was such a sobering kind of report there, and I have to say, I really appreciate it, because you only try and hear the good things, but it's one of many. That is my concern. And how many more examples are there of such kind of, looking at that video, and I thought that video was very good as well. Some things that were said there, things like when we haven't got a full complement of staff, problem is flow, trolleys everywhere, ambulance handovers. There's so many things there that kind of combine to this, yeah? And perhaps, what can I say? I think the question I've got is, we've heard earlier on regarding the 45-minute handover from the ambulances, and I would appreciate your honest kind of answers to this, and I know you will. Problem is, though, we're doing the handover, but the corridors are getting more, well, I would have thought more full. So in another way, we're pushing the problem forward, yeah? And if you look at the IPA, from what Hugh, your report earlier on, it is concerning the over 12 hours in A&E. And I just really want to know, kind of, because I myself, and I'm sure a lot of other IMs are having emails with kind of problems or people kind of concerned about how they were treated, or kind of the long delay in being seen, yeah? And it's something, we only hear the bad news stories, we don't hear much of the good news, and there's so much good work happening there. But I really want to know, kind of, we're pushing the problem forward so much, yeah? Kind of how long or how much can you take? Because the staffing levels, every one of those people there said staffing levels, kind of, where can we, or what can we do better, kind of, to try and improve that? Because I was talking to you, Chair, and kind of the others, kind of, perhaps we should, and I have been to many of the emergency departments to look at kind of the situation, and perhaps we should go more often, and perhaps just see kind of more often kind of what the situation is. We might be going on a day which is a good day, as one of the people said, yeah, kind of, but then I really want to know, kind of honestly, kind of, how bad is it?
Right, okay. We'll take a couple more views and then we'll come back to you. The thing I'd encourage you to do, I'm sure you would do this, Karen, is, we can say, well, let's look at the endoscopy example, and we could put in a fix around that, which wouldn't solve the problem. It might fix that particular patient experience. It wouldn't solve the problem. So I think there's something about trying to see this from that systems-wide perspective, to think, how is it we impact on all of this, if we've only got so much resource, time, energy, commitment, effort, where can we make the biggest changes in terms of addressing some of these issues? Eleanor.
Diolch, Cadeirydd. Diolch am y cyflwyniad. Thank you very much for the presentation. It was sobering to listen to it, and it was sobering because it felt so recognisable in what you're having to do every day. And I met Peter, Karen, Nerys before. I have a habit of walking into a department in any particular hospital we have when it's empty. Nobody can explain it. If you could bottle that and it would help, I'd be happy to do it. Keep turning up.
Because they know you're coming.
It is, yeah, and I get that. However, going back to this, when I was listening to that one individual example, yes, it's bad for that one individual, and the sliding doors image is really important. What I was trying to think through is, as Mark said, what can we do as a health board? What can we do in hospitals systemically to try and make a big difference? We talk about delayed discharge of care. We talk about less waiting time in ambulances. One of my constant questions is, do we ever look at the impact of one thing has on another and the holistic system that we have to make a difference? And I'd like to hear two things from you. One, if you have thoughts about where we make that difference. And two, to express my enormous thanks for the people who work with us and work in emergency care in this space, and just express a care for their well-being and what we can do around that, particularly in light of if it's a good day, it's because we've got the right number of staff in, and that really strikes home with something we shouldn't tolerate as a board. It should be better than that.
Okay, I'm going to take one more comment from Chantal, and then I'll offer the floor back to you, Clyde, and the team. Chantal.
Yes, thanks, Chair. And indeed, a lot of the comments that people around the table have made are, I'm making very similar comments, because I think what we need to be focusing on the systemic solutions rather than looking at things within a very narrow lens, because clearly there is an issue in terms of the way in which we are having to manage demand. That's having an impact not only in the way in which we deliver the care, but also how it impacts the staff. And I could hear that from the video that was being played with the staff that gave their comments. And I'm particularly interested in the sort of things that we're doing in order to provide the support to the staff, who clearly is having conflicting moments in terms of how they're delivering the care, in particular in light of their professional the professional standards and the professional requirements that they should be implementing in terms of managing patients.
Thank you. Okay, so Sharon, you want to come in? So we've just come to Sharon.
Sorry.
And then,
Thank you,
and
Chair.
then you may want to respond.
Thank you for that. I think just building on what Chantal said, really, we do need to be solution focused. But I think, in terms of the story, Clive, I was just thinking around if we could look at that through the clinical, as a clinician, and in terms of not just the professional standards, but professional accountability, the clinical judgment. How does that impact the clinical judgments that we make? I mean, from the story, it sounds as if that lady actually went home and came back to sort of planned endoscopy at a different time. But it's how do we balance those risks within the context in which you're working, and how do we, as a board, support our clinicians to make those decisions and ensure that we've got the right governance around that decision making as well.
Great. Okay. Right. That's it. You can.
So if I come back in to start with, and then we'll hand over. If I come to you, Karen, for the alternative solution, I think the important thing to remember here is that this patient story, this case here, did need to be in the A&E department and did need to be in a hospital. The question is, how do we make room for those people to get into the service and have the right service in the right place? And I think some of that is around some of the alternatives that we'll be talking through now. So I'll hand over to Karen, and then we'll work from there. Then I'll come to Vicky to talk about the staff and how the staff are coping, because Vicky's working in that ED environment every day.
Thank you, Chair, and thank you, Board. If we think back to July when I was last here, we presented a model outlining alternatives to admission. And I think if we look at the situation that faces us for our population, we have a capability challenge. So across our wider systems, balancing the demand with the professional ability, so that professional standards, staffing levels, professional role and skill set, and shared decision making with our citizens in where they want to be cared for, we're in a very challenging situation. So there's lots of things that we've been looking at doing. One of those that we're really passionate about facilitating is shifting care into the community, so providing alternatives for patients that don't need to be seen in A&E. Now, this case clearly highlighted a patient who did need to be in A&E, and actually the care was compromised in multiple ways because of a capacity issue, essentially. So the integrated urgent emergency care model with the clinical streaming, with SDEC, with hospital at home, with our community services providing alternatives, as I mentioned before, could account for about 50% of the activity that's currently coming through our accident emergency front door. The other thing that was really quite pivotal in this case was inequitable access to services. So we need to have a 7-day health and care system, so that whatever day of the week a citizen's medical, functional, social need is, that there's equity in access to that. And that's something that we will be coming back to talk to you about again, I think, in the new year. I think one of the key things that we have to champion as a health board is right-sizing our staffing models, so safe staffing, so that professionals can deliver the care that they're passionate to and are skilled to and trained to deliver. So in this example, very difficult to find a space to talk to the individual, to maintain dignity and privacy, notes that the individual couldn't be examined, difficulty in administering safe treatment, investigations that are needed, and a safe sort of follow-up plan. So huge compromise in terms of the role that the individual was able to receive, I suppose. So one of the things that we're very passionate as clinicians to facilitate is to think differently about the care that we deliver. So historically we've been very site-focused, our budgets are site-focused, but actually what we want to do is unravel a patient journey, think more birth to end of life, and actually how do we support people with chronic disease, access to care when they need it across our systems. So think about specialty care pathways, so whether that is a parental-ology sort of oversight. So many of our patients in the communities have specific disease profiles and have specialists that they're under, and actually we need to make sure that this is dovetailed to our acute sites, that there's communication between crises and that chronic disease management, and a lot of those entities can be supported more by multidisciplinary teams in the community, and care can be delivered in a different way. So there's very much a clinical desire to move more to a specialty care pathway way of working. The modernisation of medicine, we're much more subspeciality focused, and actually how do we deliver equitable care for all of our citizens across Hywel Dda, rather than a historic, trust-based, site-based focus. So really it's thinking about our population health requirements and making sure that our establishment is right-sized to that, and thinking very bravely and differently about how we enable that within our financial profile, I suppose.
Thank you.
Thanks, Karen. Thanks for that. And also, I think it's important to note the environment in which we are trying to work as well, our estate and the condition of our estate, and what that means in terms of delivery of the services. But I'll just hand over to Vicky now, who's working in that ED department every day, and the impact on how that feels alongside Neris, and how that feels for the staff and what that means in terms of delivery of care.
Good afternoon. I'm Dr. Vicky Hughes. I'm an emergency medicine consultant, and I've been a consultant for about 16 years. But I've been with the Health Board for about 2.5 years. I've really enjoyed my time working in ED, despite the many challenges and the things that we're discussing. And it is, don't get me wrong, a very challenging environment to work in. But I'm privileged to work with some exceptional people who are incredibly motivated to deliver compassionate, dignified care, but every day struggle with the fact that it's hard to do that because of the barriers we talked about, problems with flow, the problems with crowding, problems with staffing, recruitment, retention, the problems with developing the kind of quality and experience and skill mix of staff that we need to work in modern day emergency medicine. So those things are all massive challenges, and we're not unique. These challenges are throughout the NHS. They're not just in Wales, they're certainly not just in West Wales. But from my experience of working quite broadly across the UK, we do have a unique set of challenges in terms of our geography, in terms of the demographics of our population, which also includes those, not only the patients, but who we pull to work with us. So that's really challenging in itself. Healthcare in the 21st century is a specialist subject. It is increasingly specialised. And with the best will in the world, we're not going to be in a position where we can have hospitals that have every specialty embedded and working in our systems. But that means we can't draw on the right people because they may choose not to work in environments like that. So it's very hard to get the level of experience of staff that you want to be working and need to be working in your hospitals at the front door, that can supervise juniors, that can help grow your own, because you can't grow your own without some experienced people around. So these are real challenges, and there's no easy fix. There's no two things we can do that's suddenly going to make this better. In addition to that, we are working within a constrained envelope financially, and we have to understand where do we spend that money to get the best impact for all of our patients. I think we're all really unified in understanding that delivering excellent patient care is what all of us want. And you can hear from the examples there in terms of the video clips, how we're very aligned as a team. We've got really clear objectives. But it's just how do we cope with the demand? How do we turn up every day? How do we keep doing it if we don't see change? And as you mentioned, the 45-minute handover pressures in terms of ambulances, yeah, absolutely, they do add another challenge. But we also don't work in silos in ED. We understand that in the community, someone's lying on the floor with a fractured hip and is desperately waiting for that ambulance. And that's all of our responsibility. Within the hospital setting, within the inpatient setting, we appreciate in the emergency department that there are really difficult challenges to discharging patients safely. And the last thing we want is people to be rushed out of hospital in order to create a space for the next poorly person to come in, because that patient may well just bounce straight back into hospital again because we haven't completed what they needed and we haven't sent them home with all the right things. This isn't just within healthcare to resolve. There's a huge element of this is social care, and we've all got to be working together to understand how we can match what is in the future an ever-growing demand that isn't going to change. So we know in ED, every day we turn up to do the job we do, and yes, it is very, very challenging. And Neil, as you described, for an outsider coming in, it looks like chaos. But I would say quite confidently, it isn't chaos, it's what we're used to, and that the lead clinician on the shop floor and the lead nurse will know every single patient in that department and will have an understanding of where are they sitting in terms of clinical risk, and that process of triage and repeated triage is happening so that we can try and ensure that those that really need to be in ED get the care they need, as Clive's example showed. Now, we are human, And I don't think anywhere in the NHS anyone could say 100% of the time we can maintain it. But we do our absolute best to deliver that. And I am confident that most of the time, for those patients, we do the absolute best we can. As Karen alluded to, one of the issues we have is that potentially up to 50% of patients who attend our emergency departments could have their care needs better met somewhere else. Now that is very challenging for us to then see who really needs to be there and where do we need to ensure we're focusing our resources. So for example, who can wait longer? Who can sit in a chair and wait? And if there is an opportunity to stream them, having triaged them, send them to somewhere which is more appropriate to meet their needs. But if that service isn't there, isn't accessible on a Saturday and a Sunday, then the only place often they have is to stay in the emergency department. So that was a very long-winded way of answering your question.
That's excellent, and I think we're pointing towards here, aren't we? We're hearing what the answers might be, and we're understanding. And we've talked before about shift left and move into the community, and the question, the big question to us all is, how do we do that? How do we do that in the same running order as having to deal with a day-to-day situation that we've got going now? How do we shift left without shifting left and have what potentially might be a double running cost of how we do that? And that's the question, the dilemma that we are dealing with every day. That's we're scraping and scrimping to get services into the community, and we've got some good services that are developing in the community, but we need to make them sustainable. We need to make them 7 days a week. We need to work in closer partnership as a region with our local authority colleagues in delivering that sort of key people at home. And we can't do that at the moment because of the constraints of the boxes that we've got labels on. So Karen's point around, looking at things differently and not looking at the buildings as the answer to the services, but the services and the pathways being the answer is the way forward. Our big question that we will be sharing with you again in January, I think, is how do we do that whilst also maintaining the services that we've got there at the moment? It isn't going to be a flick of a switch one day and it all changes. It's got to be a period of time that we run that in over.
So it's not a question in January, you've got to come up with a solution. However challenging or courageous or unpalatable, we have to go to that place. We have to go to that place. I think your point is well made, Karen. I think it's about the service, not the site. We have to work with our population to get them to understand and appreciate that as well. But unless we are being brave about making those changes in the future, then I have a terrible sense that we'll carry on. We'll carry on as a board. Kind of, it's not that we're complacent, but we will be tolerant of what we think is a poor service being delivered through this, both for staff and for individuals. And we don't want to be that anymore. We can't afford to be that anymore. It's exhausting you, and it's not allowing us to, to create the best possible environment for you to work in. And it's certainly not meeting the needs of patients, as you've described, Clive. So we have to get to a solution. And as unpalatable as that might be in terms of what changes it might mean broadly for others, I think we've got to take that step. And I think you've already started to articulate what you think some of that solution might look like. And it might be 7-day working, it might be reconfiguring where those services are delivered, how and when. All of those kinds of issues will be really important. The thing I would say is it absolutely has to be data-driven in terms of being absolutely certain this is the right thing, because we will meet quite a lot of resistance inside this place as we try to take forward a programme of change. And the one thing that we can rely on is the evidence that says this is the right thing for us to do in these circumstances. That has to drive it.
Yeah, I think also it's important for us to get closer to our population as well. As a community and integrated medicine team, we've got to get closer to our population and work with our population on a locality basis in a much more joined up way. And that's partly what we're talking through now in terms of how we structure ourselves as a care group to be able to get closer to the population, closer to our GP practices, closer to our communities in terms of taking that forward. And I don't know whether Anna wants to add a little bit more to that in terms of community district nursing and how that fits into the jigsaw, because I think that's an important element of how we move forward.
Great.
Thank you, Peter. Yeah, we focused very much today on talking around our ED department and the staff that we have within our ED department, but I think it's really important that we recognise the huge wealth of experience, skills and competencies that we have within our community staff as well. So in terms of how we develop, build and enhance that capacity within our community teams is going to be crucial in terms of how we support. We've talked around systemic solutions today, and ultimately we're not going to be able to achieve this without addressing all areas of our systems, from primary care, community, intermediate care and obviously secondary care. So the skills, the competencies, the workforce that we have in the community are going to be key in terms of how we move forward with this. So we're looking at obviously our community capacity from a district nursing perspective, looking at how we can enhance that to up to 80% of our current weekday capacity to ensure and enable that continuity of care for community patients across the 7-day working week, so that maybe on a Thursday or Friday, when maybe at the moment someone may need to come into hospital for that care, if we've got the correct resources, the correct workforce and skills in the community, we would be able to maintain and manage that individual, that person at home without requirement for that hospital admission. So I think that's going to be key, is the skills, the competencies, the training and the enhanced establishment of workforce across that 7-day period in the community. We've also got our hospital at home teams, and again I'm keen to look at how we develop the ability for staff to work much more generically across the community. So looking at understanding the competencies and the more acute management of illnesses in the community who may historically have needed to come into a hospital secondary care setting that ultimately don't necessarily need to. And I think that's going to be a huge change for workforce, but also for patients to understand that they don't necessarily need to come into hospital. We do have the skills, we do have the competencies and the ability to look after patients in the community. And then from the other side of the coin as well, I'm talking from a system perspective, patients that require discharge from hospital, it's how we enable that much more supported discharge earlier on in the journey. So rather than waiting for every box to have been ticked, that actually we can take patients home much sooner, utilising those enhanced skills and the capacity that we've got.
Very helpful. Thank you, Anna. I'm going to come to Lisa, and then I'm coming to Hugh, and then to the boss.
Thank you, and thank you all very much for everything that you've said today. I think one of the things that, there's a couple of things that have struck with me really, Anna, certainly what you've just been talking about, and Karen as well, around the community resilience and how we build that model. I think what we have proven in the last few years is when we really set our minds to stabilising our nursing workforce, we had a plan about how we were going to do it and how we were going to introduce it. And I think what we're seeing with the community at the minute is we get small pieces of money on a non-recurrent basis at short notice, and then we recruit to those posts. That then destabilises the staffing in the hospitals, because very often they're the people that will do that. And I think what we need is that proper workforce plan around what do we need, what are the skills and the roles that we need in the community, and then set ourselves up to, so how are we going to deliver that in a proper, focused, managed way, rather than the little bits and pieces that we do now. And if we think about the money that we put into the Nursing Act to stabilise the wards, actually, if we got that right, some of that wouldn't need to go there. So financially, it could square itself out at some point. But it's not the same process as it would have been for the wards, which was about agency. But I think if we had that proper focus, more could be achieved.
I agree.
Thank you.
I agree. Hugh.
Thank you, and echo the points around sobering nature of the discussion. Thank you for sharing the examples and case studies. I think it's really illuminating for us and the public to see those stories. So just a couple of reflections. And Karen, to start with, I just wanted to pick off your comment around budgets and the way in which we manage budgets. And I agree with you completely. I think we need to be much more flexible about the way in which we are able to move resources around our system, because we need it to move from areas that are currently sustaining or delivering us suboptimal outcomes into those areas that will deliver us the best outcome and the best value for our system. I guess in some ways, the delegation of the budget from the board is purely down to the clinical care group, and it is within the gift of the clinical care group to then divide that budget up accordingly. So we could split it up, as we currently do, by site on that historic basis. We could do it by patient cohort. We could do it by pathway. There are a number of ways in which we can do it. But whichever way we do it, we will end up with silos. Whichever way is going to be imperfect. And I think there's something much more important about our collective leadership and our behaviours that we adopt in this space in order to be flexible in moving our budget around, because whatever configuration will need a move by definition. Around double running costs, I absolutely recognise that in any transition from one state to another, there is going to be a degree of double running costs. I guess my caution is less to do with the funding here and more to do with the challenges that we would have with workforce, because there's only so many people out there that we have working with us at this point in time, and recruitment is a challenge across many services. So it is inevitably going to be a shift of workforce from one way of working to another that we need to be reflecting on. So double running, if we were able to just move the budget and have a degree of double running costs, that would be relatively easy. The challenge is going to be around how we bring people along with us.
Thank you. Really important. Great, okay.
Diolch, Cadeirydd. Look, thanks so much for coming today. I know for some of you, probably it's not the sort of environment you're used to speaking in, so really appreciate that. And I think it's really important for us to hear the stories as it actually is out there, as our staff are feeling it. So I think the way you've done that, I think, has given us a good sense of that. A big thank you to the staff you're working with out there on behalf of all of us. When I go out into the EDs, I try and pass on our thanks to them, but I know how difficult it is for staff on most days, and an apologies to our public who are on the receiving end of the inconsistent patient experience. And to be fair, most of us, pretty much all of us, live around here, so we're also part of that together. I was going to just dial up the driver for change, I suppose, slightly, that we think we can't cope now, but when you look at the demographic predictions in the next sort of 15 years, it's incredible just how our demographic will change. The largest amount of older people alive and the smallest number of younger people economically active. So it's not just for the challenge we have now that means we've got to make a change. It's actually safeguarding things for the future. So I suppose when you look at the inconsistency of our service, when I look at it, it's interesting, even over a weekly period. Actually, it's quite consistent how it seems to get really difficult over the weekend. We have a real struggle on Monday, Tuesday, then sort of starts to get better on Wednesday. Thursday is the best day, and then Friday we're all worrying about the weekend, and then it goes round again. And this happens every single week. I can see everybody nodding, and that is problematic. We have to do something about this. I mean, we are the board. We've got our clinical leaders here. The great thing I would say is I think, Vicky, it might have been you said we're all aligned actually in what we're trying to achieve, and that should give us, I think, the courage to take sort of steps forward, because we're all together on this, and I think our public are pushing us. What we need, I suppose, is a sense of what we should do first. What would be most impactful in if we're moving towards a 7-day service, because it feels like we need to. You've mentioned it. We have to build community capacity and capability. So what do we do first? You've mentioned some of the things, Anna, but when you come back, it's just working out what do we do, because it'd be, as Hugh sort of say, it would be quite difficult to do everything all at once, unless you're suggesting we need to do that, which would be, I'd understand that, but I suspect there'll be some things which are higher impact than others, and we need to be data focused and evidence based. So to give us the confidence, I suppose, to be really courageous in this, and if we can continue with this being clinically led, the fact you're here today, we're going to need that really strong, courageous clinical leadership with our clinical execs as we approach this. But yeah, I suppose all this does is increase my personal determination to improve things, but also I'm sure us collectively as a board.
So I'll make a final comment, but I wondered if there's anything else anybody wants to say before we close.
Vicky, I think, wanted to make another comment.
Vicky.
Yes, thanks, Bill. And I think we're all in agreement about the need to think about those resources into the community and for the longer term future. But I think bringing us back to the now and what do we need to do, and the concerns and the case that's been raised and the comments from Neris around corridor care within our emergency departments is, I'm sure we all and the public want to ensure they feel confident that when they need an emergency department, that they will get the care they need in that setting. And I think we have to make sure we all understand that where we currently are sat, despite everybody's best efforts, is that we do have crowding in our departments, we do have ambulances waiting outside, and that patients are not necessarily in the right clinical space within that department. And that does mean delays to their care. We also recognise that the ratio between patients to consultants, patients to nurses, and although for nurses there's a legal framework for that within hospitals, there isn't within the ED, is that we have quite we have high numbers of patients to the numbers of nurses, high numbers of patients to the number of consultants. And we are a bit of an outlier in that in Wales. And so we are working at that. We're looking at a workforce plan. And I'm really pleased that we have a stronger clinical voice to advise and to bring our expertise to the table and to challenge. But when we think about the right now, our ED departments would require significant investment to match the demand that we currently see, let alone in the future. So that's capacity in physical space, the right physical space, the right number of staff with the right skill mix, and the wraparound support services in terms of labs, imaging availability, which is 7-day. Flow is a big part of that. And that, again, discharge profile needs to be 7 days a week, not lots of discharges on a Friday with nothing on a Saturday and a Sunday. So I just wanted to bring us back to, yes, the longer term in the community, but also the right now, here and now, where is our gap?
Karen.
Thank you. Just to add to that, I think we do have a plan in mind collectively of where we want to get to, and I would say it's an incremental one. So if we think of our aspiration, our ambition, what our future we want to look like in terms of social model for health and well-being, a good life well lived, then there's that intermediate bit, which we could call Horizon 2. So what do we do in the short term that builds that path, brick by brick towards the future that we want? And I think incrementally, there needs to be a reduction in pressure on the acute sites, and the integrated urgent emergency care model brings some of that story. So the streaming element, access for people to right care, right place, right time, having alternatives for people to go to physically, such as same-day emergency cares rather than ED, looking at our urgent primary care model and how that sort of dovetails. So there's a clearly articulated vision where we want to get to. So that is something we need to look at, how we phase, how we transition, how we move the resource, because it's not just about money, it's about people's time, it's energy, it's attention of what they're doing. And we've got a fantastic workforce, and that is a huge asset, not just in terms of sort of capital assets. So it's how we get to that. But I think one of the key things we need to do in parallel, and Mark is very passionately championing this, is our clinical workforce plan. So we need to get to a point in the future where our medical workforce planning is robust like our nursing, but it's modernised, it's thinking about our MDT, our advanced clinical practitioners, our allied health professionals, and as Vicky said, those services and those interdependencies, the diagnostics, etc., so that we have a holistic care experience for people when they need it. And at the moment, the data shows that our services are not equitable through the week, and we do have that inconsistency. So I think whilst we're building that future and we're looking at what things we invest in to get that incremental approach, we absolutely need to aim for consistency and reduce the inequity that people have on the different days that they access.
Very helpful.
Just to reassure Vicky on one thing. So my comment about being drawn from the future and the demographic challenge that is coming wasn't to suggest, and therefore we can delay that, because don't worry, it's a while before that happens. It's more about it's going to be even more challenging than now. So it's an even stronger drive for change. So it wasn't an argument for delaying this, just to reassure. I mean, and the other thing I was going to say, I think behind your polite point about the workforce model, I think, because we've discussed this, is that our ED medical staffing model is quite different to what you would tend to see in the kind of major centres across the rest of Wales and mostly in England, because we are split across 3 ED sites, and indeed we also have another site that doesn't have an ED. So and it's not just the ED, actually all of our medical staff in different specialties are split, but it has an impact, because it means that you've got relatively small numbers of ED consultants on each site, and in fact very, very small numbers in some of them, and there's no doubt that influences all sorts of things around the kind of timely care or patient care or quality care that we can provide. And it's something I know that you're thinking about, and how we respond to that, and draw in the rest of the hospital medical staff within that. But we do have to face that also as a board, that there is a difference in the way our ED medical staffing model works at the moment, because of all the because they're spread across the sites. Yeah.
So to kind of draw it to a close, I mean, first of all, the slides. Thank you, Andrew, for the preparation of the slides. If anything, the slides suggest to me there's lots of work going on to try and address some of these issues, and that work will continue. So it felt to me as if nobody was complacent inside this system. There's lots of work taking place to try and address some of the challenges. And you're right, Vicky, it's not a tomorrow thing. We absolutely need to address these things today. We can see the pressure and the fragility of our services, and the model is dysfunctional. It's dysfunctional. It's the multi-site kind of nature of this makes it a dysfunctional system. The question is, how radical can we be in that space? And how do we take our population with us in terms of thinking about some of those things? And how can we ensure that we are evidence-based when we make the kind of what are going to be unpalatable and difficult decisions in the future regarding these services. But I think one of the things I think that I hope that we're starting to do much better is we're starting to listen to our clinicians, and we're starting to trust in the leadership of our clinicians to be able to work out what needs to be done differently inside this space. And I find that reassuring. I also find it quite exciting, because I think you are best placed to know what the answers and the solutions are inside this space. That doesn't mean that we won't be presented with a headache over resourcing or funding or any of those other things, but that's for us to think about. Your job is to think about how we make these things better using your clinical expertise to drive that. And I know Mark is doing that, and we have those conversations every day. So I suppose from this board, I want to say that we are endorsing your ability to decide what you think those things might be in the future. And there may be things that we need to do in the very short term to address those issues. We will work towards that January date for looking at something fairly substantive inside this space. I think everything you described, Karen, in terms of the holistic approach is absolutely the right way forward. We have to do that, to address the stuff that you're talking about in the long term. But there is a short-term agenda we need to think about as well. We can't just think about that. We have to think about the people who will come in and use the service tomorrow. And we have to think about the demand on that service and the staff who are having to deliver that and their well-being, as you've indicated, Eleanor. So the thing I would say is you have license. We're giving you license to go away and be radical. We might wince and be a bit uncomfortable about that, but we are giving you that. We are giving you that right, because you are the experts and the lead clinicians inside this space. We will worry about all the remaining bits. And my last comment is just to say thank you. You do a fantastic job. You do a truly fantastic job, and we are humbled and deeply grateful for the work that you do. Thank you.
Thank you.
Great. Great, okay. Okay, I'm conscious we are, in terms of time, we are way behind in terms of our agenda, but I think that was a really important session for us to have, and to have a good, fulsome conversation. I have a feeling we could talk a lot more than we have done, but I think it's a really good start to being able to have that open, public, honest conversation about what we think is happening inside that space. And I think our clinicians need to feel, at the very least, valued. And the way in which we can communicate that value is by making it clear we're listening to what they're saying, and that we give them credibility to know what is the best thing to do inside this space. Great. I want to move us to Nurse Staffing Levels Act, annual presentation of nurse staffing levels. Before you start, Sharon, I'd just like to say this is the paper that, for me, wins the best award. This board.
Champagne.
The reason why is because it's the paper with the longest sentence in.
Oh, you said that last time.
77 words in one sentence. I think we could learn a lot from Fleiss in terms of their report management. 77 words. We do not think in 77-word sentences, okay? It's not literate. It might sound technically correct, but it's not literate. So my sense is, let us try and work. And actually, there were a few others with 65, 57 in other papers. And I thought, well, I won't draw attention to those. I'll just work out who the winner is. Who the winner the board is on this occasion. Yeah. Let us try hard to when we're thinking about writing these papers, be aware of who will be reading them. So it isn't just a translation of technical information into a paragraph-long sentence. It's about recognising the fact that people will need to read this, and we never learned to write 77-word sentences in school or university or anywhere else. I know we didn't, and I'm sure that's the case. So I can see you all counting now, but please don't. But just to note, that's the case, and perhaps you would, because it undermines the quality of the paper and the hard work that's gone into the work behind the paper. That would be my view.
Thank you for that observation, Chair. I thought I had gone through and reduced that, so I should go back and check my track changes. Thank you. So I'll be brief if that's okay with you, Chair. I mean, I know that the board is well versed on receiving this annual presentation, and I'm happy to bring new members up to speed on the Act itself, if after the meeting, if that's required. So basically, the paper presents the annual nurse staffing levels report for the Health Board in compliance with the Act. It outlines our statutory requirements, the methodology and the outcome of the autumn review cycle. In summary, I'll just focus on the changes. So to the 31, 25B areas, and as we touched on briefly earlier, these are all adult inpatient medical and surgical wards and our children wards as well. So 28, there was no changes in this cycle. There was a change in 3 areas. One was around an adult ward in Prince Philip, where we reduced the number of registered nurses at night, and this was in relation to different ways of working. There has been a change in Bronglais on one of the wards in terms of the healthcare support workforce is now been extended overnight rather than a twilight shift. And there was a slight change in one of the paediatric wards, and that was because of the change in proportion of long days. The financing arrangements for the establishment are sufficiently flexible to be able to respond to those long day and traditional shift pattern changes which we see every time we present the report and I do the calculation cycle. So I bring the annual report once a year to the board, and then I take an insurance report into QSEC once a year as well. So we have 2 presentations to board, and the 3-year report came into board last year. So with that, I'm happy to take any questions if there are any.
Thank you, Sharon. Very helpful. Colleagues, any questions? It's all very clear.
After the sentence.
Despite the sentence. Great, okay. Can I suggest then we take assurance that we are meeting a statutory duty to calculate responsibility? Is everybody comfortable with that assurance? And that we're meeting our statutory duty to provide annual presentation to this board? And also our statutory duty under paragraph 21 of the guidance. Okay, great, thank you. Let us move then to report of the Audit and Risk Assurance Committee.
Okay, thank you. Diolch yn fawr, Cadeirydd. Thank you. Can I just briefly go through the meeting that was held on the 14th of October. As you can see from the paper, we kind of wish to advise members of the board that the validation of emergency department waiting time data internal audit was a limited assurance. Also, the Human Tissue Authority internal audit was also limited in assurance. Regarding the assurance then, just one thing that was noted, the escalation status update. I think we want to reiterate concerns around the Welsh Government's changing expectations in terms of the financial target, and the committee requested that clarity be sought from Welsh Government in relation to the governance processes for changing de-escalation criteria. I'll quickly go through most of the kind of report then, and perhaps just touching on the financial assurance report. The committee took assurance on actions to address breaches of standing financial instructions, to reduce staff overpayments and instances of non-compliance, to ensure public sector payment policy compliance, to manage single tender actions, and to ensure national minimum wage compliance. Counter-fraud update, that was an interesting report, noting the various proactive exercises undertaken in respect of prevent and deter activity. And I'll finish, I don't know if Chair you want to go through the recommendations. It's just one to note and one to take assurance of.
Okay, thank you, Rodri. Colleagues, any questions? No? Okay. Let's note the item the committee is advising us of. Thank you, Rodri. Let us move to report of the Quality, Safety and Experience Committee. Eleanor.
Thank you. Thank you very much. In Anna's absence, I'm going to take it that you've read both the reports on different dates. All the advice categories that are in there have already been discussed at board today, including the public interest support, the unscheduled and emergency care, quality assurance, paediatric improvement action plan, and the other one, urology. And as we've already discussed them, I don't feel the need to go through in any more detail.
Great.
But happy to take questions.
Colleagues, are we happy to note the items the committee is advising us of and to take assurance from the item it's providing assurance on? Yep. Great. Okay. Let us move to report of the Finance and Performance Committee. Michael.
Thank you, Chair. I think, as is common these days, that virtually all the issues on this have been discussed today. So all the alert advisor and assurance matters, and a number of these, again, are going to be on our agenda for our meeting in just over 3 weeks' time. So these are kind of fluid issues which are being well examined today already at the board level.
Great. Okay. Thank you, Michael. Right. So we need to deal with some approvals relating to procurement, which is part of this report as well. Shall we deal with those?
Chair, I'm happy to take the paper as read, and I'm happy to take any questions on those. Just to note, though, that there are a number of particularly healthcare-related contracts which have got increased above £1 million in terms of the cumulative spend with individual suppliers, which will are coming here for that reason.
Great. Okay. So we're asked to approve the award of the All-Wales Standard and Custom Procedure PACS Framework Agreement. Everybody comfortable with approving that? Okay. And approve the award for insourcing of theatre scrub team. Yep. Okay. Approve the contract change notice for insourcing of first outpatients appointments. Yep. And approve the award of the multidisciplinary design team for the Bronglais Hospital Fire Improvement Scheme for the period of December 25 to the 26th of April 2029. Yep. Great. Okay. And then for noting the cumulative contract value, which exceeds £1 million for the Circle Health Group, the Spa Medica, Healthcare Business Solutions, and also the award of the insourcing of dermatology procedures contract for the period of the 1st of August 24 to 31st of March 25, with the option to extend to the 31st of March 27. Great. Okay. I see nods around the table.
Chair, there are a couple of others as well. The All-Wales Bread, Milk and Baked Goods contract and ASD.
Yes, we had a lot of detail in there, which I was getting into as I was reading it. Notably, are we buying it from Scotland, or are we, are we buying it from locally, even if it is more expensive?
We benchmark against prices available in Scotland because they also do an all Scotland process. But obviously timing differences on benchmarking make a big difference, especially on food where inflation has been particularly high in recent years.
Yeah, great. Okay. Are we happy to endorse, note, approve the additional contract? Great. Okay. Thank you. Thank you, Hugh. Thank you, Michael. Let's move to report of the Strategy and Planning Committee.
Thank you, Chair. Most of the items have already been discussed in relation to Horizon Issue. The only item that we probably haven't touched on is the Emerging Capital Risk Programme, where I think it's associated, attached to this paper, are a list of schemes in Annex 1, which we're asking the board to approve, which require sealing.
Great. Okay. Thank you. Thank you, Winston. So is the board happy to approve the application of the seal for all the schemes listed in Annex 1? Note the items that we are being advised of and take assurance from the items we're being asked to assure. Great. Okay. Can I move us to the report of the People, Organisational Development and Culture Committee. Helena.
Thank you, Chair. Just to draw the attention, thank you, Lisa, draw attention to the Social Partnership Duty Annual Report, which is the next paper here. The committee discussed it, was very content that it came to board for approval, so we'll take that as the next paper. There are no alerts. There were several deferred papers for this, and this has led to discussions about the need to get the approval of chairs of committees to defer papers in the future. And two of the papers in particular, it's really important that they're coming back to the next meeting. One is around sickness rates and cultural challenges in our theatres, and the other is on the recruitment process in the CCG structures.
Okay. Okay, thank you. So we're asked to, Lisa, anything you want to add about the Social Partnership Duty Annual Report?
Do you want me to do it? I mean, it was Ardiana's paper.
Ardiana, I'm very happy for you to...
Yeah, thank you, Lisa. And to add, I'm presuming that colleagues have read, so it is the first report that we're doing as a board on the Social Partnership duty, as that it has come into force as of April 2024. It has gone through the process of approval with our staff, etc. So I'll take any questions, and Lisa, please help us out.
Fine. I was going to ask Anne to perhaps add a word in view of her trade union kind of partnership responsibility.
Thank you, Chair. It's been a privilege working with your team, putting this together, and they have really implemented the use of the trade union. They've met us twice in our chair and group meetings. Any adaptations we added or columns, they are willing to take that on board. And it actually proves that actually we stand quite out against other health boards on the collaborative working we do, which is really thanks to Lisa in COVID, who brought us all together, had us meeting every Tuesday, and that's carried on. Yep. We have one meeting a month with Lisa with organisational issues and 2 meetings a month with operational issues. So some of the issues like that identified aren't going to a head because they hit court really on, and we involve everybody to discuss it. And the relationship we have with the organisational relationship team, that has really brought group issues that we work with workforce, with OD and with the unions to a head. And we had a presentation in the middle of the summer in Cardiff, and people were really impressed with our workforce and union collaboration, and it comes out well in that paper. So thank you very much.
Great, delighted to hear so. Thank you. Great, and thanks to Lisa as well.
Thank you very much. That's really reassuring to hear and to know that. It's a great thing. The more partnership we can do in this space, the better. So it's very, very good. Okay, so are we happy, board, happy to recommend to accept the approval of the Social Partnership Duty Annual Report? Great. Okay. Can I move us to item 28? And I'm going to come back for you to the report of the Health and Safety Committee.
Thank you, Chair. There's nothing to alert at the moment, but there is advise. The Health and Safety Subcommittee provided an update on our manual handling training compliance, which is currently only at 58%. So the teams are going away and working on that. And we also had a paper on stress at work, which we didn't gain much assurance on, so we've asked them to go away and come back with that. The rest of the items are under assure, so I'll assume you've read that, and that's my report.
Great, thank you. In my head, I was making a correlation between musculoskeletal reasons for sickness absence and the level of training of people who've completed the training in manual handling. I wonder if there's a correlation between those two things, because it feels to me as if it's such a big issue for reasons of people being absent or unable to work. We do need to drive this a bit more.
Thank you.
Great, okay. Let us move on to report of the Charitable Funds Committee. Hywel.
Diolch, Cadeirydd. Taking the report as read, and just to briefly highlight, nothing to alert or advise, but in terms of assurance, there were 3 applications for expenditure which were approved at the last committee, one being the Therapeutic Gardens of Prince Philip, the other being in terms of the Heads Up initiative, which is for hair loss services through cancer services, and also in terms of the arts programme, which again has done some amazing work and continues to do so. The other kind of important thing about charitable funds is that we also, at meetings, routinely get feedback in terms of evaluations of impact, in terms of where the funds have gone. And we also had 2 presentations in terms of from the Haematology Clinical Nurse Specialist for Ceredigion and Pembrokeshire on previous funding that had been awarded there, and also in terms of older adult mental health and adult frailty inpatient wards through the interactive singing and movement sessions, which we had funded as well. I think the other difference, perhaps, which again in public board we should note, is diolch yn fawr iawn, thank you to all those members of our communities across the 3 counties who continue to raise funds for our charitable funds. Because we often kind of talk about the projects, but none of these projects would actually happen without the funds which are raised from our amazing communities who do so. So thank you to them.
Diolch. Yeah. If we could, Claire, if we could note that in the board minutes, that would be excellent. Okay. Yes. Thank you, Yuan. So we'll take assurance from the items that Ewan has drawn to our attention. Maynard, report of the Digital Data and Innovation Committee.
Met on the 7th of October. The committee has no items which to alert the board to or advise the board to at the present. So they're assured are all there listed for you.
Very good. I note radiology programme December 25, this December. I just wondered about the scale and scope of that.
It's not tomorrow, it's Saturday. That we'll be taking the decision to go live. So the process is underway, and I'm assured over the activities that are being undertaken.
Fantastic.
There's a lot of work being done by a lot of people, though, which worthy of thanks. So we might bring something back through the committee and through to board.
I think that would be very helpful, because it feels to me it's accelerated very quickly, and it must have been quite a priority for people to just work around it.
It's worth noting there are a lot of implementations going on live between now and the end of March.
It's a busy time.
Okay, well done, well done to the team, because I have no doubt that's enormously challenging. It's complex work and often difficult to make happen. Let us move on to committee update reports. Just to say we take assurance from what you've indicated, Maynard. Committee update reports, Jo.
Yeah, thank you, Chair. So these are all of our other committee or advisory groups to the board. So you've got updates from the ethics panel and from the in-committee board, but everything that was discussed in the last in-committee board has been through the public domain today, Chair, and from the Health Professionals Forum. I wasn't going to go through the paper, and just if there were any specific questions to take those, Chair. A couple of advisors, but no alerts to the board.
Great. Is everybody comfortable with that? Yep. Great. So just to take assurance from the items that we're being assured of. Let us move to item 32, which is joint committees and collaboratives.
Yeah, so this is the update on the Joint Commissioning Committee, Shared Services Partnership and Mid Wales Joint Committee. Wanted to just highlight in the Mid Wales Joint Committee that was held, you can see the progress that's been made there on quite a whole variety of areas, plus the fact that the Rural Health and Care Wales Conference took place a couple of weeks ago, which I thought was excellent. I did attend and spoke at it, and there's an intention to relook or to look at the priorities that were set back quite a number of years ago, since the Longley report, the Mid Wales study back in 2014. So there is a plan as a Mid Wales Joint Committee to relook at those priorities. You'll see there. The Joint Commissioning Committee papers are from previous meetings, and there was a meeting on Tuesday, so I thought it'd be worth Lee just giving us a quick update on a couple of issues that came out of that before we go to the recommendations. I'm sure on the shared services partnership, Hugh, who attends that for us, would be willing to take any questions.
Thank you, Phil. Thank you, Chair. So 2 points I'll bring to board's attention from the meeting I attended on Phil's behalf on Tuesday. So, firstly, board members will recall the changes proposed around the EMIT service, and obviously there was within that a recommendation for around additional provision in rural areas of Wales. We discussed at that the work on that had been paused whilst the judicial review was underway, quite understandably. So we discussed at that that work will now recommence and be incorporated as part of the IMTP or annual plan development within the JCC. For board members to be aware of that, and certainly within the discussion, a number of people stressed the importance of that recommendation, not least to maintaining public trust in the process that we've gone through. The second point to recognise was that the financial forecast for JCC this year is quite considerably in excess of the original plan, around 7.7 million. So actions are going to be considered to try and bring that back, but obviously at this stage it's very unlikely that we'll get back to within the original plan, which puts a pressure on all health boards, including ourselves. The key discussion within that was not just this year, but also what that means heading into next year and beyond, with obviously the same challenges that we discussed earlier in our finance report. It's worth noting that JCC funding this year from health boards was far in excess of the allocation uplift. So even though we had some very difficult choices to make in relation to in those services, and there was an option to go beyond that, and we're still overspending beyond that uplift, we are putting more money into special services than we are to other parts of our system. And obviously that's just important in the strategic context that we talked about earlier. Thank you.
Thank you, Lee. Hugh, did you want to? No, you're okay. Great. Okay. So, so we're being asked to receive the updates in respect of recent joint commissioning committee updates and the NHS Wales Shared Service Partnership Committee. Approve the updated JCC standing orders. Are we happy to approve the standing orders? Great. And also to approve the updated All Wales Individual Patient Funding Request Policy. Adoption from the 1st of December. Yep. Okay. Great. Okay. Let us move on to item 33, which is statutory partnerships update. Jill and Andiana?
Yes, thank you. So Ardiana will pick up PSBs, but just very briefly in terms of Regional Partnership Board, the RPB, as we've said in previous meetings, continuing to redefine its purpose and wanting to be much more responsive to the community, looking at that more integrated approach and trying to move away from an over-reliance on short-term funding in terms of the way in which it delivers care. So the report sets out the journey, I guess, that the RPB is going on, and I know we've confirmed in the board minutes that the Chief Executive will be joining the RPB as our health board representative in that capacity, so I'm sure that journey will continue.
Yes, please.
Thanks. Thanks. From the PSB's work, I would just highlight just a couple of points. From the Ceredigion PSB, the food resilience workshop took place, and that is, as I highlighted earlier, in support of the food accessibility and healthy weight elements. The Carmarthenshire PSB presented and agreed the regional structure options paper, which then will come for next time for approval, which is around the working of the 3 PSBs, and considered the Carmarthenshire and Ceredigion joint climate change risk assessment. In the regional structure, so the regional structures around the PSBs, Pembrokeshire PSB also considered the options paper, and there was no agreement for a whole one regional PSB structure from the Pembrokeshire PSB, but there was an agreement for a more collaborative working across the 3 PSBs. The Pembrokeshire PSB has also decided to invite Future Generations Commissioner to a future PSB to consider how the Future Generations Act supports and enables better regional partnership working. And the Older People's Commissioner has visited some parts and will be coming to a workshop in February, which we're invited for the Pembrokeshire PSB. And those are the highlights. Thank you, Chair.
Thank you, Adriana. Thank you, Joe, for that, and we take assurance from that as the board. Maynard.
There was just quickly for me, I noticed in the outcome of the workshop, there was a desire to establish a regional digital strategy and improve data sharing protocols. And just wanted to flag that and make sure that we are heavily involved in that when it starts taking forward.
Good point. Yeah.
Yes, we will be.
Yes, there is a complex Venn diagram of regional activity because, of course, we've got our joint work with Swansea Bay Health Board and our region with our local authorities. So there is a complex navigation for us to make sure we can work within both of those contexts.
Great.
But it's something I'm conscious of and we need to build on.
Great, okay, thank you. As long as we're mindful of that, I think that's the most important thing at this stage. Thank you, Hugh. Any other business, colleagues? No other business? Okay, let's formally close the meeting. Thank you.